A very good morning to all of you, and thank you for coming, because today is a match day and I hope that we will leave you on time. What is our match time? Everybody knows the time. So yeah, ready to go as soon as we finish. Okay, India will lose the toss and New Zealand is batting first. Okay, yeah. So this is how the day goes for us. First, we'll play 2 short games where I'll do a session with the audience. Then we'll have Dr. Amit Vora, who will come up on stage and we do an interview lecture with him. The interview lecture has one requirement that it'll be about 90 minutes, and the last 15 minutes or so will be dedicated to Q&A from the audience. And of course, then we'll hand you the mic and you can ask your queries. Most of the queries will have been solved by my question and answers. So those who repeat questions will be proven to be sleeping during the lecture. So don't do that. And after that, there'll be a break, 15-minute break. Snacks can be purchased outside. Uske baad, there'll be a stage quiz. And we have 2 teams who we have informed on the phone that they'll be participants of the stage quiz. The stage quiz is a format where 3 people on each team, 2 teams, and if they turn out to be weak teams, meaning if they don't give 2 answers correct consecutively, we will reinforce the team with a 4th member, and then a 5th member, and a 6th member, till they get all their answers correct. Each team can have, therefore, maximum of 6 questions. Each team also will have a captain. Dr. Kumar and Dr. Mukesh Bhamre will be captains of the 2 teams. And a special question has been framed for each of them, for each round, which will be the most difficult question, and which they have not prepared, which I have kept it with myself. I must tell you that Mukesh and Kumar have been the backbone of the preparation of this whole. So please give them a big hand. Mukesh is here, Kumar is there. Okay, so we'll start. Amit bhai, this is a game which you should also play. It'll be slightly embarrassing to stand up, but you will have to stand. No, that you can leave. You can of course take it. In this game, we will be doing on neurology. We'll be standing up. I'll be reading out names of conditions within neurology. The condition will be either predominantly unilateral or predominantly bilateral. You have to guess which. If it is predominantly unilateral, you will have to raise your right hand. If it is bilateral, you have to raise both hands. Those who do it correct stay standing for the next. The others will sit down. The last 4 people standing get the prize. Is that okay? Maybe please stand up. It is neurology, unilateral or bilateral, titled Adha Adhura Ya Pura Ka Pura. Okay. I'll just give you an example. Frontal lobe disease in Alzheimer's. Unilateral, bilateral? Yeah, okay, so you know the thing. Okay. Alzheimer's predominantly affects not the frontal lobe, but that doesn't matter, right? Okay, we go to the first. Restless leg syndrome. Unilateral or bilateral? Everybody got that correct? Thank you. Those who don't get it correct will sit down voluntarily. We don't have volunteers to make you sit down. Guillain-Barré syndrome. Don't speak, just raise your hand so that your partner, thank you. Yes, bilateral is correct. Cluster headache. Okay, this is a few wrong. Okay, it is unilateral. So those who said bilateral will sit down, please. Trigeminal neuralgia, predominantly unilateral or bilateral? Is correct. Unilateral is correct. Early phase of Parkinson's disease. Okay, we caught some people here. It is unilateral. So those who said bilateral can sit down, please. Yeah, That is the maximum sitting that we have seen so far. I need people to sit down. I have only 10 questions. Okay. Herpes zoster is correct. Jacksonian march, a form of epilepsy. Jacksonian march. It is unilateral. It's a focal epilepsy, unilateral. So others can sit down, please. Neurogenic claudication. Neurogenic claudication. It is bilateral. So I'm sorry, but it is due to lumbar canal stenosis, bilateral. Essential tremor is bilateral, is correct. Vestibular neuronitis. Vestibular neuronitis. Predominantly unilateral, all got right. Temporal arteritis at onset. Unilateral is correct. Unilateral is correct. Diabetic sensory motor neuropathy. That you got. Bilateral. Meniere's disease at onset is correct. Unilateral. Optic neuritis in multiple sclerosis. Many got that wrong. It is unilateral. Horner syndrome in Pancoast's tumor. It is unilateral. Unilateral, बेचारे को दो जगह पे कहाँ तुम malignancy दोगे? Todd's paralysis. Todd's paralysis. Always unilateral. It's a focal epilepsy, and following that there's a paralysis. Optic neuritis in multiple sclerosis. Did I do that? No. Yeah, sorry. Ethambutol ocular toxicity. Ethambutol ocular toxicity. Bilateral is correct. Bilateral is correct. Sorry, sir. So, paralysis in infarct. This is a little difficult, so I have to get you down. Paralysis in infarct of an unpaired anterior cerebral artery. Infarct in unpaired anterior cerebral artery. It is bilateral, sir. It is bilateral. How many standing? 3 standing? Okay, I need 2 standing. Acha, we said 4 standing, right? So we give 5 prizes. आप दोनों भी जो थे, can you give 5 notebooks from there, please? No, not this, those. A big hand for all of them. Thank you so much. We will be discussing some of these later. And the second game is related to the topic that we are going to come to with Dr. Amit Vora. In this game, which is called Aadhe is taraf, Aadhe us taraf, we will be all standing up again. Please stand up. Sir Amit bhai, I'm so sorry. You can't play. Okay. I'll state a cardiology fact. It may be a fact, it may be untrue. If it is false, you have to turn to the left. If it is right, you have to turn to the right. Right statement, turn right. On your seats only. And those who don't have it, do it correct, they sit down. We have, again, prizes for the last people standing. And this time we have only 1 prize. Now, syncope is correctly pronounced syncope. True or false? Yeah, right is right. Syncope is the correct thing. In a syncopal, it's now called syncopal, not syncopal, it's called or something. In a syncopal episode, consciousness is always lost. True or false? Always lost. Stress on always. Misleading stress on always. It is always lost. It is true. Yeah, I could get some people to go down. Yeah, Consciousness is always lost in syncopal episodes. A few seizure-like clonic jerks may happen in syncopal episodes. True or false? Seizure-like clonic jerks may happen during syncope. It is true, it may happen. So false is wrong. It is true. A few patients may take up to half an hour to regain consciousness. True or false? A few patients may take up to half an hour to regain consciousness. I did not want such a large elimination so fast. It is true. It is true. Up to a few patients. Most recover very fast, but few will take some time. Syncope occurs and fall occurs due to sudden loss of blood flow in the lower limbs. True or false? False. It occurs in the brain blood flow decline. Next, tricky question, so be careful. Foul-smelling sandals and pungent onions can startle an unconscious patient of syncope into sudden recovery. True or false? Some of us still do believe that. It is false. Okay. First dose syncope is a symptom associated with antihypertensive drugs like alpha blockers, prazosin and terazosin. First dose syncope can occur due to alpha blockers like prazosin and terazosin. True or false? Good prompting? Yes. And accurate prompting, which is important. It is true. Now let us see whether you can prompt rightly. Prostate-specific alpha blockers like tamsulosin do not cause first dose syncope. True or false? Prompt, audience? It is false. They can still cause, even if they are prostate-specific, so-called, they can cause first dose syncope. So we have a few here still remaining. Heart rates below 40 and above 180 are most likely to cause cardiac syncope. True or false? Below 40, above 180 is true. You got that right? The typical syncope seen in aortic stenosis is syncope on exertion. True or false? Is true again. In patients of SVT, syncope is less common than palpitations. True or false? Syncope is less common than palpitations. It is true. Holter monitoring monitors the heartbeats for up to 7 days. True or false? Up to 7 days. True or false? It is false. We don't call it Holter then, we call it something else. We'll come to that. Diabetic autonomic neuropathy can cause syncope. True or false? Everybody got eliminated except one. Thank you. She wins the prize. It is true, diabetic autonomic neuropathy can cause postural hypotension and syncope. Oh, she's also there? Okay. Give one of these. This was same. Because we are now doing arrhythmias with sir, so I said we'll prime you with some syncope. May I call Dr. Amit Vora on stage, please? And let us welcome him. Ayati, Amit bhai. Amit bhai, this might be a better way. Praful, हाँ. Thank you for coming. Soon. Yes, sir. जितना हो सके उतना पास नहीं ये सब सेट किया है ऑन कराना चाहिए सर के लिए वो पानी इधर नहीं माइक दे दिया Okay, first of all, of course, about mobile phones, you know that it is all about the charge of the phone and charge of the speakers. The more your phone rings, the more charge or power we lose. So please silent, vibration or off if you can. Thank you so much. Maro phone nathi ne chalta. Okay. First of all, a slightly embarrassing disclosure. This fit man is the same age as I am. We are the same batch. We are the same batch. He was from KM, I was from Nair. And of course, we introduce the speaker through the speaker. You know, so that what people send their bio, and that is read out by the introducer. We prefer that we ask you some questions which are sometimes embarrassing, but you can answer. Okay, so first of all, you did your MBBS, MD, DM from?
KM.
All from KM?
All from KM, yeah.
Okay. Just check the sound, sir का sound, sir थोड़ा soft spoken है, तो उनका sound बढ़ा सकते हैं, नहीं तो we can ask him to be close to the mic. Yeah. Okay. You chose cardiology, and then how did you do electrophysiology?
So cardiology in KEM, 93 I finished, and then electrophysiology was an upcoming field. So the Department of Cardiology at KEM had people who were interested in arrhythmias, Dr. Ivan Pinto, Dr. P.A. Kale. So some amount of ECG arrhythmia interest was there, which was kind of percolated to all the residents. And electrophysiology was an upcoming field world over, with the advance of pacemakers, defibrillators, and radiofrequency ablation. So that's how actually I was very lucky that one of my friend, he's also Jayesh Thakkar, our batchmate, he was in US. He called me over after I finished my DM cardiology that come over, just see what's happening in US in terms of advances in cardiology. And luckily I went to the electrophysiology department, which was very well kind of progressive. And it interested me a lot. So after a short stint, I came back, and then we said that we should set up this subspecialty in cardiology. And fortunately, our head of the department in cardiology that time was Dr. Hema Kulkarni, and she also was very futuristic. So we set up this electrophysiology department with Yash and me, pediatric cardiology with Bharat Dalvi, structural interventions coronary with Praful Kerkar. So all of us went abroad for training and came back to KEM and set up this subspecialty. So it was very interesting.
Wow. And you now have a private practice with in a kind of joint or partnership with others?
Yeah. So I think, you know, Yash has been 2 years senior to me, and right through the MBBS and post-graduation and cardiology, we were together. Ashish Nabar is 2 years junior to me. See, we all grew up together. So when we started private practice, we in fact formed a group, Arrhythmia Associates, and all three of us worked together.
Okay. About your personal life, your family, who are they?
So my wife is a gynecologist. She's from JJ Hospital, and always that rivalry of KM JJ continues at home also, at least in the initial few years. And so she's doing her private practice. She has a maternity home at Kandivali, and my daughter is just got into, she's in second MBBS.
Oh, wow. And any parent doctors?
No, so I was the odd one out. And so you know, the advice which I got all from my family members and relatives was that I should finish my MBBS and start general practice. I think, so, you know, and we were discussing the other day, actually general practice is very, very important. The more I specialize, the more I realize that y'all are the first line of defense for, all general population. And therefore, we should strengthen the general practice as much as possible. And I think this academic initiative is great. And I always love to interact with GPs.
Yeah, and though this is called the first line, often these people are so well trained that in some cases it becomes the last line of defense also, right?
Yeah, because I lost very miserably in the neurology round. I was down and out.
Okay. What are your chief regrets in medical career? Chief regret in medicine?
Well, I guess one of the regret is that, so academically, once you get into private practice, the academics do take a back seat. So academics can be in various fronts. So I think as far as CME is concerned, teaching and learning is concerned, that I continue doing. But what I probably miss out on is doing some, basic research and trials and studies, which a platform is very much possible in a government medical college and hospital. So that is my, from 93, 94, after I finished my DM cardiology, I was 7 years in KEM, and 2000 I started practice. But yes, I think the regret was that if one were to be affiliated to KEM in a more capacity, then much more academic work could also be churned out. So research in our country is still, it's happening, but it's lacking, and there needs to be more input.
So when you said you went abroad, learned there, they were fairly advanced. Currently, what is the gap between the West and India in terms of how many years we are still lagging behind in electrophysiology, in the field of that? How close are we? How far are we?
I think we are pretty close. So I think it's been now more than 2.5 decades that, in India also, we started in 96, 97, and it's 2.5 decades. And all over the country, electrophysiology is picked up remarkably well. So I would say that we are almost at par, maybe a little lagging behind, only for the reason that this is again very advanced in terms of equipment requirements and technology. So that is sometimes prohibitively expensive for our country and for our patients. So some of these things come a little late, but otherwise we are up there.
Wow. Okay, so we'll start with the formal talk now. So first of all, these are family physicians, as you know, and they should know what does an interventional cardiologist do, and what more do you do over and above the interventional cardiologist as an electrophysiologist. So what are the specific areas of electrophysiology that most interventional cardiologists do not touch?
So I think as an electrophysiologist, we manage arrhythmias much more. So both brady and tachyarrhythmia. For bradyarrhythmia, pacemakers are the common interventions that we do. And for tachyarrhythmias, it is radiofrequency ablation for the SVT group of patients that we do. And for ventricular tachycardia, we do ICD defibrillator implantations. And there have been a lot of progress. So now heart failure is becoming a major area where we are focusing, because heart failure patients, to improve their left ventricular function in terms of interventions, cardiac resynchronization therapy or biventricular pacing has come in, and they have a higher risk of sudden death. So ICDs get implanted, and they have a lot of atrial fibrillation. So atrial fibrillation ablation may have to be done. So I think atrial fibrillation, heart failure is becoming the new cardiology epidemic, so to say.
Because of aging.
Because of aging, absolutely. So all the patients with hypertension, diabetes, all the basic risk factors, they are being managed well, they are living longer. As they are living longer, they are getting into more advanced cardiac problems, and heart failure and atrial fibrillation has become the major thing and become a kind of specialty on their own. And yes, so we see and manage many of these.
So just because all of us family physicians, especially the ones who have been practicing for decades, we have to realize that our geriatrics department has to be strengthened very much, because as people grow older, as he said, heart failure, possibly due to diastolic heart failure or ischemic heart disease causing systolic failure, And then of course arrhythmias, we get more AV blocks, we may get more sick sinus syndrome. These things are going to keep on increasing. So while we have not really concentrated in learning those areas very carefully, the time has come to do that. So we'll start with one condition, and that is sudden cardiac death. Lot of talk on various social media of people dying suddenly, younger people dying suddenly. First question to you is, do you think it is a real statistical increase in sudden deaths, or it is just more reported?
I think both is happening. In fact, it's sad. Today morning only I was looking at one of the messages. There have been 9 sudden deaths in Gujarat yesterday. So Navratri festival, unfortunately, we see higher incidence of sudden cardiac death. And so now we knew about it, but now it is getting reported. So now we know the exact number. All through the days, apparently more than a couple of dozens have happened. But the sudden cardiac death definitely is increasing. So if you look at the age population of, just taking this example of this Navratri time when people have died, from 13 to 62 years of age, people have died.
From?
13 years
13.
of 13 to 62 years of age, people have died. So younger people are getting into sudden cardiac death. And yeah, the awareness is building. So people are now reporting it. What was going unnoticed or unchallenged is being reported. And therefore, I think both is happening. There are more number of sudden cardiac deaths happening, and there is been better
awareness. So there are two kinds of sudden cardiac death. I will segregate it in two parts. Sudden cardiac deaths in younger people and sudden cardiac deaths in older people, because the etiology or causation might be a little different. So first, let us talk about what are the possible causes of sudden cardiac death in the younger population. How will you define young? And in the younger population, is it different from older?
So yes, I think sudden cardiac death in young is different from older people for sure. And this is what we need to understand. So general cutoff is taken at 35 years. 35 years age younger is the young sudden cardiac death. And young sudden cardiac death is generally because of cardiomyopathies. Okay. Amongst the cardiomyopathies, hypertrophic cardiomyopathy is the commonest cardiomyopathy. But then you can have non-ischemic cardiomyopathy. And then you have various channelopathies, ion channel defects. So you have long QT syndrome, you have Brugada syndrome, arrhythmogenic RV cardiomyopathy. So all these, and congenital coronary anomalies. So all these form into the young sudden cardiac death group. And 35 years and above, we generally call them in the adults, the cardiac death. And the commonest in 80% of them is going to be coronary artery disease related. 10 to 15% will be still cardiomyopathies, and then less than 5% would be other channelopathies and valvular heart disease.
So I'll just summarize this for you, because you will have to put it down in your notebook and make it a point to read these areas. Younger people, hypertrophic cardiomyopathy, sometimes what he said is non-ischemic dilated cardiomyopathy, and channelopathies. Now, these terms are often not known to us very well. Brugada or long QT syndrome. These we will have to become familiar with. And the younger people therefore die due to these diseases, a sudden arrhythmogenic death rather than a death due to myocardial infarction. Is that, whenever I'm wrong, you will have to correct, because I'll summarize a few things for them.
Absolutely.
And the older people, 80% of them have ischemic heart disease related deaths. Sudden cardiac deaths. Again, these deaths can be sudden, meaning you will get death due to arrhythmia, but the arrhythmia is due to coronary artery disease. So that is the older person. So can we discuss the younger deaths first? For the family physician, what instructions do they have to give to their patients to prevent young deaths? For example, what instruction can be given during Navratri?
Yeah, I think so. Prevention of sudden cardiac death is a big thing in itself. And I guess as far as prevention is concerned, there are two things. One is we have to focus on coronary artery disease, and the other is we have to identify people who could have cardiomyopathies and channelopathies and stuff like that. So when we are talking of young people, and especially when people are getting into sports and competitive sporting activities and stuff like that, what kind of a screening or what kind of questioning or what kind of examination should be done? I think it's important that you have to remember what we discussed, syncope. Syncope is a very common symptom, and it happens very frequently. Vast majority of the syncope are benign in nature, but some of the syncope can be life-threatening. So today's syncope could be tomorrow's sudden cardiac death. And that is where we have to kind of differentiate, which is a malignant or danger-looking syncope. And in young people, when we are wanting to avoid sudden deaths, we need to identify in young people when they have had syncope, is it that danger variety or the common vasovagal neurocardiogenic syncope? Vast bulk is going to be that. But the malignant ones are, they will have certain characteristics. So if you have any of your young patients who have exertional syncope, so, even not only in aortic stenosis and coronary artery disease, but the young, long QT syndrome, it can be an exertional syncope. What we call as catecholaminergic polymorphic ventricular tachycardia. It is again a channelopathy where exercise-related fainting or syncope happens. Even with arrhythmogenic RVD. So many of them, exertional syncope is dangerous, in short, for the young also. Syncope which leads to fall and injury. Now that's a border zone. It can happen with the benign syncope also. But if it's significant fall and injury, loss of consciousness being there, some resuscitative efforts are required in young people, then it is dangerous. So if it's causing injury to a person, always think that, rule out malignant causes. Syncope, if there is a family history of syncope or sudden death, I think family history is very important. You need to, every person whom you are trying to evaluate should ask, is there a family history of sudden death? Anybody dying at young age? Because that will give some clue that, okay, then there could be, because all these cardiomyopathies and channelopathies, they do have a familial inheritance. So then they have a genetic tendency. I mean, coronary artery disease also is known to have, but these are much more likely to have. So in young people, when we are wanting to look at these things, I think that is what is important.
Recurrent syncope, would it be a problem?
Yeah. So if you have a recurrence of syncope, so correct, vasovagal or neurocardiogenic, which is common.
Can be recommended.
Some lifestyle measures you tell them or guide them in terms of hydration and stuff like that, they tend to become less and less. As child grows, he grows over it and he does not get the syncope again. But the malignant ones, they tend to recur despite these general guidelines. So that would again raise a flag that this could be a malignant syncope. So I think...
would syncope occurring in the supine position, I don't know whether there is such a thing, like something like Stoke-Adams, would that be a syncope? Would it defined as syncope?
Yeah. So I think any transient loss of consciousness with near spontaneous recovery is defined as syncope. And yes, so that's the way, one of the ways of saying benign versus malignant. So if you had somebody having, in a standing position, prolonged standing, in the heat, dehydrated, you know that this is likely to be a hypotensive or a bradycardic episode, vasovagal variety. But in a lying down position, if you had such an episode of loss of consciousness, falling from the bed while he's sleeping, that should raise an alarm again that this could be a malignant cause.
So just first of all, vasovagal, which is synonymous with neurocardiogenic syncope. So vasovagal, all a person, especially a young person, maybe a tall or whatever, has a lot of pooling of blood in the lower limbs, standing in the train for some time, heat, and they fall. You know how to identify a vasovagal. But the red flags are what we should be more interested in. And these red flags, you should keep in mind that they are predisposing a person to sudden cardiac death. So one is syncope as a symptom to identify future sudden cardiac deaths. Any other red flags in a patient besides syncope which can tell the GP, or should they evaluate every athlete who does high intensity exercise?
So I think that's the very important thing, because after the history taking, where we talked about any symptoms of syncope and family history, the examination is equally important. In the physical examination, cardiac examination, if you have evidence of any abnormality, because hypertrophic cardiomyopathy and all that can be missed, but if any abnormality in terms of a cardiac enlargement, murmur, anything is there, you should definitely then get an ECG done. ECG is a good tool to pick up many of the cardiomyopathies and channelopathies. Having said that, ECG also can be normal, especially for many of the cardiomyopathies at an early stage. And therefore, in our country, especially, an investigation like echocardiogram is fortunately very easily, readily available and not very expensive also. So I think in athletes, there is actually a little bit of divide between US and Europe. US recommendations are that they would just stop at general examination, at the most do an ECG. In Europe, they do an ECG and they also consider doing an echocardiogram because picking up of cardiomyopathy is very important. I think we are fortunate, it's readily available. So everybody getting into competitive athletic sporting activities, it is worthwhile to have a proper clinical evaluation, which includes an ECG, and echo should low threshold.
As young as how much age? I mean, if they have a grandchild who's 12 years old and a squash player, which is a high intensity sport, should the grandchild of 14-year-old?
So no. I think not every child who wants to pursue a sporting activity should be considered. Only if he has had symptoms,
Okay.
or is there a family history, or in your clinical examination you found something abnormal, then you do
only
it.
ECG.
Then only you do it. And once they get into competitive sporting activities, now all athletic bodies have become very aware of it. So then they will further screen.
Give me examples of abnormalities on echo that are the red flags for future sudden cardiac deaths. What will you see on echo?
So on an echo, as I said, most often what we want to pick up is a cardiomyopathy, and hypertrophic cardiomyopathy being common. So the prevalence of hypertrophic cardiomyopathy is fairly high. 1 in 500 individuals tend to have hypertrophic cardiomyopathy. So on an echo, once you see a ventricular septal thickness, which is more than 15 millimeters, you should have a suspicion that this could be a hypertrophic cardiomyopathy. Because again, there is a lot of overlap between hypertension patient having left ventricular hypertrophy as opposed to a hypertrophic cardiomyopathy. How do you differentiate the two on an echo? So one of the simplest things is if the thickness is more than 15 millimeters, you should rule out hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy also has a cavity chamber size, left ventricular cavity chamber size very small. It squeezes blood completely, very small and thick muscles encroaching the cavity. They will have left atrium which is dilated. They get into diastolic dysfunction. So these are the cardiomyopathy features on the echo which we look for. We could also pick up non-ischemic dilated cardiomyopathy in terms of dilated heart. So many of the patients are so well kind of get tuned to the illness they have that they don't realize they regulate their activity so much that they are not symptomatic. So symptoms may not be there, but on the echo you pick up that there is significant, LV systolic dysfunction that's happening. Valvular heart disease, congenital heart disease that can get picked up. Coronary anomalies in the young that can be picked up on the echo. So
Aortic stenosis can be big.
aortic, I think that's important. Aortic stenosis is important. It occurs more frequently in the elderly group, but young people also will have bicuspid aortic valve and aortic valve stenosis, coarctation of aorta. So bicuspid aortic valve disease is one of the other valvular diseases which can lead to syncope and even a cardiac arrest.
Okay, so when you said hypertrophic cardiomyopathy is seen, I'll stick with hypertrophic cardiomyopathy for now, is seen on an echo. How does hypertrophic cardiomyopathy kill?
That is important to understand because the hypertrophic cardiomyopathy again is a genetic abnormality of the myosin light chains of the muscles. So basically what happens is the myocardial cells are abnormally enlarged, they have abnormal disarray, and eventually apoptosis or cell death tends to happen, and there is a fibrosis. So thickening of the myocardial cells, abnormal orientation of the myocardial cells, and eventually leading to cell death and fibrosis. So whenever fibrosis occurs in the myocardium, that is the reason why they have arrhythmias and sudden death. So hypertrophic cardiomyopathy, because of fibrosis, leads to arrhythmias, ventricular fibrillation and death. The same thing with coronary artery disease. When you have an infarct, you have a scarred myocardium, there's a fibrosis, and therefore they are more prone to developing arrhythmias and sudden cardiac death.
Correct. I'll just tell you this, that the group that we are on, which is called the SOS registration group, 900 people are there. Some of you have attended. On this group, tomorrow evening onwards, we will be putting up these topics with short videos on the same group, not only for revision, but also for some more detail, which Mukesh and Kumar have prepared. So there is one small article on hypertrophic cardiomyopathy, for example. So that you can revise, because not everything will be probably easily registered. Within hypertrophic cardiomyopathy, some people, meaning there are two types, obstructive and non-obstructive. What is the importance of these two types?
If you take all hypertrophic cardiomyopathy, almost 70% of them will have some obstruction. So what do we mean by obstruction? What is an obstruction? Obstruction of the outflow tract. So with the hypertrophic cardiomyopathy, there is a predilection towards hypertrophy of the septum. The proximal septum gets very much hypertrophied as opposed to the other wall. It's not a generalized hypertrophy. Generalized hypertrophy more often happens with, hypertension related hypertrophy. This has some regional involvement, and septal thickness becomes much more. So when the septum becomes very thick, it encroaches on the outflow tract, and then you have the mitral valve. And because of the Bernheim effect, what happens is that whenever there's a blood pumping across the outflow, because of the hypertrophied septum, it actually sucks in the mitral valve, and the anterior mitral leaflet comes towards the septum, further aggravating the outflow flow of the blood. So this is the obstruction. So this is called a systolic anterior motion of the mitral leaflet. When in systole, the mitral leaflet should close, anterior mitral and posterior mitral leaflet should close and be away from the outflow tract. The thick septum sucks the mitral leaflet towards it, and therefore creates a gradient, so to say. So whenever on an echo we have a outflow across the left ventricular outflow gradient of 30 millimeters or so, we call it a obstruction, because this is a dynamic obstruction. So what happens at rest, you may be 30, but if you do exercise, it may become 50, 70, or even more. So when you have in all hypertrophy, if you have obstructive cardiomyopathy, they are more symptomatic. And in terms of the long-term prognosis also, they are more likely to develop various problems, be it mitral regurgitation, be it atrial fibrillation, be it sudden cardiac death also. So obstructive variety behave more malignantly as the non-obstructive variety.
So just to clarify, the outflow tract that we are talking about is the left ventricular outflow tract, which kind of aortic valve could be synonymous with the outflow tract. The gradient that he's talking about is the gradient across the valve, meaning the velocity with which, just correct me, I may be wrong, but velocity with which blood flows across the aortic valve. The greater the velocity, that means it represents a greater stenosis. The more the stenosis, the more will be the turbulence and the velocity. Bad or good?
No, correct. So this is to differentiate from the aortic valve. This also used to be a subaortic stenosis kind of a thing.
Okay. Correct. So when you have a patient who is reported to have on an echo an aortic stenosis or subaortic stenosis, and there is mentioned two things: the valve area, aortic valve area, and the gradient across the valve. What can they understand, and when do they kind of have worry about those two readings?
Yeah, so aortic valve area and gradient across the aortic valve, peak and mean gradient across the aortic valve. These are the important things which will determine the severity of the aortic stenosis. So whenever you have an aortic valve area which is less than 1 centimeter square, and if you have a gradient which is more than 50 millimeters of mercury, this is the peak gradient more than 50 millimeters of mercury, it generally is a significant aortic stenosis. And in terms of intervention, when do we intervene? I guess when the gradient becomes more than 70 millimeters of mercury across the aortic valve, we consider that this is high enough to have higher cardiac events, and therefore you should relieve the aortic valve by whichever technique, surgical or now even the transaortic valve replacement. The problem comes, these gradients are very important, but the valve area is equally important. Gradient is something which is commonly reported by many people, but valve area is something which a more accomplished or a trained echocardiographer will report. because many times these patients of aortic stenosis develop over a period of time left ventricular systolic dysfunction. It has to pump against a closed aortic valve all the time. So there is a LV systolic dysfunction. When there is a systolic dysfunction, the gradient falsely will become low. So the gradient reported is 30, 40 or 50 or less. But that does not mean that the aortic stenosis is not severe. The aortic stenosis can be still severe. In fact, it's worse when you have an LV systolic dysfunction with a relatively gradient of 30, 50. And that's where the aortic valve area helps. So aortic valve area is more relevant, more important when there is LV systolic dysfunction. When the LV function is normal, you can just look at the gradient and decide on the severity.
You just saw that how I seamlessly but erroneously transitioned from hypertrophic cardiomyopathy to aortic stenosis, for which I'm sorry. So we will go back to hypertrophic cardiomyopathy for a bit, then we'll go back to aortic stenosis. So hypertrophic cardiomyopathy, you have found that there is hypertrophic cardiomyopathy. They sometimes do an MRI to detect scar tissue. And does that become important for therapeutics?
Yeah, so I think in a hypertrophic cardiomyopathy, it is very important because again, that is one of the cause of sudden cardiac death. So who's at risk of sudden cardiac death is what you need to identify. And you know, all this sudden cardiac death, primary prevention is the key because you know, survival of a patient who has a cardiac arrest is world over very poor. In India, virtually it is negligible. So if a person has a cardiac arrest, eventually dies. So the whole challenge for the medical fraternity is to how to identify who's at a high risk of developing sudden cardiac arrest and prevent that altogether. So in the hypertrophic cardiomyopathy, there are certain risk factors which we look into, which are high risk, and then we should intervene much more earlier. So there are certain echocardiographic criteria. So one is the ventricular septal thickness. Normally is 1.1 centimeter, 1.5 we said is HCM. But if it becomes 3 centimeters or more, then it is very bad. If you have a left ventricular outflow obstruction with a gradient of 50 or 70 millimeters of mercury, then it is bad. If you have a atrial dilatation which leads to atrial fibrillation, then it is bad. Now, if this patient has a history of syncope, that is very, very bad. If this person has a family history of premature sudden cardiac deaths, family known to have hypertrophic cardiomyopathy, then they are at bad risk. And there is a scoring risk also available where you can identify the number of risk factors. With more number of risk factors, there is a higher chance of you having sudden cardiac death. Cardiac MRI has become a very important tool nowadays in terms of our ability to identify scarring of the myocardium. So actually, for ventricular arrhythmias to occur, we know all structural heart disease require scarring, and that scarring promotes arrhythmias. How do we identify scarring? If it is very, very gross, like an ischemic heart disease and scar, echo can do it. But in hypertrophic cardiomyopathy, echo cannot identify scarring. That is the limitation of an echocardiogram. And therefore, MRI has become a go-to tool for all cardiologists and electrophysiologists when we want to pick up the high-risk group to ask for a cardiac MR, because cardiac MR can identify the late gadolinium enhancement, which picks up the scarred myocardium very well. And then we look at the percentage of scarring. Anything which is more than 20% of myocardium which is already scarred, the risk of developing arrhythmias is very high, and therefore they need to be considered for an ICD implantation.
So if you identify a high-risk individual with hypertrophic cardiomyopathy, the principal treatment to prevent ventricular tachyarrhythmias is an ICD with pacemaker or without pacemaker?
So ICD is the treatment for prevention of sudden cardiac death, because an ICD, intracardiac defibrillator, basically will identify the ventricular tachycardia fibrillation, deliver a shock, and restore the arrhythmia back to sinus rhythm. So ICDs do take care of the tachycardia, but they have an inbuilt bradycardia function.
Achha.
So all ICDs have an inbuilt bradycardia function. So if the pulse goes less than 50, which is determined by us, 50, 60, whatever we want, it will start pacing. But if the pulse goes more than 150, 170, 180, we define as ventricular tachycardia, and it will deliver treatment for the ventricular tachycardia.
Give a shock inside.
Give a shock.
Okay, so Somebody is uploading from the phone. I like that. New function. Okay. So again, hypertrophic cardiomyopathy, non-obstructive or obstructive. Decision to operate, as he summarized for us, is based on the echocardiographic features, the symptoms like syncopal episodes, and maybe MRI scar tissue. And the treatment that he said is placement of ICD. A little bit about ICD. I know that we are not going to go into details of technicalities, but just what is an implantable cardioverter device? What exactly do you do?
So basically, it's very similar to like a pacemaker implantation through the subclavian vein. We will introduce a lead which goes into the right ventricle. That lead is connected to a generator. So as you know, in a person whom we want to use a external defibrillator, there are two pads, which then across the pad you deliver energy and a shock. So what this does is that the lead has a coil which will deliver the energy, and the machine, the device, which is roughly 50 to 60 grams in weight, will be in the left infraclavicular region. So a shock will be delivered across the can and the lead in the right ventricle, and therefore it will do the function of a, like what an external defibrillator does, internal defibrillator will do function and restore normalcy. So it is an implant which is done in the cath lab. It generally takes 1.5 hours to do, and you have either a single chamber if you put in the ventricle, and sometimes when you require pacing function also, then we put a dual chamber pacemaker. One wire is there in the atrium also, so helps into a proper pacing function as well.
What is the cost of ICD?
So generally cost of ICD is between 3 lakh to 4.5, 5 lakhs.
Correct. Is ICD placement also done by non-electrophysiologic interventional cardiologists?
So very few. I think pacemakers, many cardiologists do, because in their training of cardiology, some of the centers and some of the people are well trained. So bradycardia pacemakers, cardiologists do, but as far as the tachycardia devices are concerned for ventricular tachycardia and fibrillation, ICDs, generally electrophysiologists do, cardiologists rarely ever do that.
Okay. This is about hypertrophic cardiomyopathy. Is there any surgical, you said there is a very thickened septum. Is there any surgical technique to remove that thickening?
Yeah. So when you have this hypertrophic obstructive variety of cardiomyopathy, the patient is symptomatic, shortness of breath and stuff like that. So you need to relieve the obstruction. So drug therapy or medical therapy to relieve the obstruction partly is beta blockers, calcium channel blockers, and disopyramide. It was not available, that drug, but now it is available again. So these are the drugs which are first used to relieve the outflow tract obstruction. By the negative inotropy effect, it will relieve the obstruction to an extent. Some of them in the mild, moderate category can be safely managed with medications. Those, despite the medicines, have a higher gradient. Then you have to do some intervention to reduce the hypertrophy. How do you reduce the hypertrophy? So there are two ways in which you can reduce the hypertrophy. One of them is surgical correction. Surgically, the surgeon will chop off part of the septum in the proximal septum, remove the septum, so that the thickness becomes less, obstruction becomes less, things become better. And now even non-surgical technique is available, where we call a septal alcohol ablation. What it means is to create an infarct in the septal area. So the coronary angiogram, you have left anterior descending artery, you have a good septal artery. In people who have hypertrophic thick septum, the septal artery supplies blood and nutrients to it. So you go into that septal artery, deliver alcohol there, and cause a controlled infarct. Once you create an infarct, necessarily the muscle will become thin, fibrous, scarred, it will become thin, and therefore the obstruction would be removed. So these are the two techniques which are used for treating hypertrophic obstructive cardiomyopathy. Of course, the most effective technique in the long run for young people is surgical correction. It's much better rather than giving a alcohol ablation. That's reserved for people who can't be operated, very elderly, comorbidities, high surgical risk. Then you do alcohol ablation.
But this surgery or intervention does not prevent arrhythmogenic deaths.
That's right. Absolutely. So, in fact, once you do alcohol ablation, there is more proneness of developing arrhythmias because of scar. When the surgeon also does a septectomy, there's a more chance that he will damage the conduction system and lead to a bradycardia and AV block, and then we require a pacemaker. So yes, when you do the treatment for this, arrhythmia treatment unfortunately cannot be managed by these things, and arrhythmia is very common. So most patients who have undergone surgical treatment or alcohol ablation will have a ICD device in place.
So at the same time, we realize that if they have an ICD, that ICD will not prevent the obstruction causing heart failure. So if there is obstruction, the symptom is LV failure, and therefore you might need in some patients both procedures.
Yeah, absolutely.
Okay. We go to aortic stenosis because it's slightly related. Aortic stenosis, again, full one-page information will be given to you by Mukesh and Kumar. Aortic stenosis has 3 causes, I think. So age-wise, can you tell us what are the predominant causes at younger, middle, and older age?
So the predominant cause, the vast majority of aortic stenosis is a degenerative age-related phenomenon. So aortic valve sclerosis and aortic valve stenosis happens as a aging phenomenon in the vast majority. In the younger people, you find congenital valve anomaly, bicuspid aortic valve being the commonest. So aortic valve should be tricuspid, and those people who have bicuspid aortic valve from birth, they are more prone to developing narrowing of the aortic outflow because of valve not functioning well, 2 leaflets being there, they being narrow, and creates aortic stenosis. So these are the 2 broad groups which we see. And in the elderly, I think it is often missed, so also in the young. So aortic stenosis is one valve disease which oftenly gets missed because it may clinically not appear on examination on ECG, because elderly people, they may have hypertrophy on the ECG, they may have mild valve murmur, systolic murmur, may not be a classic thing, and you tend to miss it. And therefore, an echocardiogram is extremely important. And the echocardiographer also should be good to be able to pick up the aortic stenosis and report it accurately in terms of its severity. So it's a underdiagnosed entity. But fortunately now, again, as interventions are getting available for these ailments, the awareness is also equally building. Everybody's now closely looking into. So in an echocardiogram, it becomes very important. Look at the aortic valve. Is there stenosis? Is there narrowing? What is the gradient? Because now we have, for the relief of aortic stenosis, earlier only surgery was being done, but now we have a trans aortic valve replacement, so a catheter-based valve replacement being done, which is now getting more frequent. In the younger population, with the bicuspid aortic valve stenosis, generally a balloon aortic valvuloplasty is what is done. And that's an old technique, and it works very well in terms of relieving the valve in the young group.
So for the family physician first, let us tell them how do they think of aortic stenosis in a person from symptoms, and then from signs, and then of course the echo. So what are the symptoms that they will have to kind of pick up to think of aortic stenosis?
So you know, it can cause all the symptoms. There can be dyspnea, there can be angina, and there can be easy fatigability, there can be syncope. So all these are the symptoms of, so these are sometimes such common symptoms to various conditions that aortic stenosis is not thought of or not looked into. But yes, look into, when you have these symptoms, when you are trying to evaluate all the possibilities, aortic stenosis should not be forgotten, especially if you hear some murmur. So make it a habit of hearing a murmur. And in that, if you do some extra thing like a carotid thrill or a carotid bruit, you are 100% certain now that you are dealing with a significant aortic stenosis.
So also the symptoms, of course, they know are chiefly exertional to begin with. So if you have a patient who says, I do 1 round of jogger spark and I fall and become unconscious, what we call exertional syncope, might be a fairly specific, not 100% specific, but fairly specific symptom for aortic stenosis. So angina is exertional, dyspnea is exertional, syncopal episodes are.
The only thing which can mimic, which is otherwise common, is left main coronary artery disease. So left main coronary artery disease mimics very much like an aortic stenosis.
Oh, is it?
Exertional angina, exertional syncope.
Okay.
Yeah.
So these are the symptoms that make you do an ECG, a 2D echo, and of course cardiac examination. As he said, the base of the heart, that is the pulmonary area, aortic area, the base of the heart, you will hear a very, very good murmur in most patients of aortic stenosis, and that murmur radiates to both the carotids. So something that we probably will not miss. Echocardiogram, of course, as you said, will show the gradient, the aortic valve area, etc. Now you have diagnosed aortic stenosis, their work is over, they send the patient to you. And how do you say all symptomatic patients will be operated?
So symptomatic severe aortic stenosis will be operated. Those who are in the mild and moderate category generally can be conserved, but they require a close follow-up because many of them are going to progress towards severity. So any gradient which is more than 70 millimeters of mercury or any aortic valve area which is less than 0.8 centimeters square are the ones which will require, because it's a mechanical obstruction. For this mechanical obstruction, there are no medications. To relieve their symptoms, one might use some diuretics, but it is not going to relieve the obstruction. So eventually, if the obstruction is severe enough, causing him symptoms, and the severity criteria are met on the echocardiogram, then they will require a relief of the aortic stenosis.
One thing that the general physician must know is that these are elderly patients sometimes, and they also have coexisting hypertension. So what medications of hypertension may not be used in aortic stenosis, any such thing, or what are preferred in aortic stenosis?
So, you know, it's a challenging thing of managing hypertension with outflow tract obstruction, aortic stenosis and hypertension coexisting, very common to exist also. So whenever you use vasodilators in patients with aortic stenosis, you know, when you have a vasodilatation and you have a proximal obstruction, your gradient is going to increase. So vasodilators are a general no-no for people who have aortic stenosis. But those are the common antihypertensives which are used also. So amlodipine type of a drug, it is a vasodilator, but that's the most common default go-to drug with a little bit of diuretic is what is commonly used in hypertension and AS combination.
Okay. I'll just explain what a gradient is because some people may not have still got it. A gradient is the difference in the pressure before the aortic valve and after the aortic valve. The gradient is the pressure difference across the aortic valve. So the greater the gradient, the more severe is the stenosis. I think itself, is that right?
Yeah, absolutely.
And that gradient can be measured by the echo,
yes.
And more than 70 would be considered severe.
Yes.
Correct. Okay, so now we go to the correction of aortic stenosis by surgical or transcatheter procedures. So first tell us about the surgical aortic valve replacement. They call it SAVR, SAVR. What does the surgeon do? Very simply, in two lines.
The surgeon basically will, it's an open chest procedure. So the native aortic valve will be removed because it's degenerative calcific, and then it will be replaced by an artificial valve. The artificial valve generally are two types, either a metallic valve or a bioprosthetic valve. A metallic valve tends to last many, many years. These days, metallic valves are very infrequently used because long-term problems, to maintain a metallic valve function, you require anticoagulation. And anticoagulation is a great challenge when you manage it for many years. So only in young people, metallic valve and anticoagulation may have to be used. But in elderly people, these bioprosthetic valves have an average life of 15 years. A metallic valve can last many, many years if well maintained, but a biological valve, a tissue valve as you call it, will last at an average 15 years. So in all elderly population, a 15-year valve after the age of 65, 70, that is what is considered in by the surgeon. They will remove this valve and put this valve.
Life of the valve is, what did you say?
So biological valve is roughly around 15 years.
15 years.
At present. The metallic valves tend to last many years.
And the surgery for the bicuspid valve disease, you said, may have to be done at a younger age. What age?
So it again, in a very young age, if a child is growing, then we generally do a aortic valvuloplasty first. So they have to be grown enough so that repeated procedures are not required. And after they have become complete adults and it still requires attention in terms of the aortic stenosis, then balloon valvuloplasty is offered as a first choice, but many of them will have significant aortic regurgitation. Bicuspid aortic valve have this combination of AS-AR, and then surgical correction only will have to be done. So in young people, when they're fully grown and you can use a good size of the valve, metallic valve, then that's what is preferred for young people.
And metallic valve because of the longer life.
Because of the longer life, you don't want to operate again and again. So therefore, a metallic valve becomes a good choice. So anybody who's less than 50 years of age, 60 years of age, it's good choice to use a metallic valve.
And metallic valve, the disadvantage being anticoagulation for life.
So they have to be maintained with anticoagulation. That's the greatest challenge we have. Because, educating our patients is very important when they are on anticoagulation. Maintaining the INR, doing the INR regularly, in terms of drug interactions, food interactions, all these things, I think that is where you should play a more proactive role in terms of having a list of drugs to avoid, a list of food items to take care of.
The anticoagulants he's talking about is the vitamin K dependent anticoagulants, which are like warfarin. And in valvular heart disease, we don't use the newer anticoagulants.
So in non-valvular atrial fibrillation,
In valve replacement related anticoagulation,
yes,
we don't use NOACs.
we don't use NOACs.
In metallic band.
Correct.
So that in NOACs, as they know, you don't have to monitor PTINR or do dietary restrictions. Okay. About TAVI. Is it TAVI, TAVI or TAVR, TAVR?
So I think both are used
synonymous.
synonymous, yes.
Yeah, but I thought TAVR basically is
valve intervention, valve replacement. That's what.
Yeah. So transcatheter aortic valve implantation is TAVI. Transcatheter aortic valve replacement is TAVR. Technically, it is not a replacement because the original valve is kept inside.
Yeah, original valve. So in a transaortic, the original valve is not changed; it's there. Now you cross that old degenerative valve with a new valve, and with the help of a catheter, the valve is mounted on the balloon, and then you inflate the balloon, or there could be self-expanding valves, which will then crush the old degenerative valve on the sides of the wall, and the new valve will come. It is based on a stent, and then the leaflets are there within, and it's a biological valve.
Biological made of?
So it's made of pig tissue valves or bovine.
Okay, so
the material is valve to valve different.
Based on the religion of the patient, do you choose the valve or do you don't tell them? I'm just asking.
No, so generally it's not, I mean, people don't have a problem with what valve it is, as long as they will say which is a longer lasting valve, which is a cheaper valve.
Wonderful. Okay, so this procedure is done in the cath lab, done by electrophysiologists or cardiologists, both?
So this is now a separate field. Now there are a group of people called structural interventionists.
Oh.
So earlier interventional cardiology would encompass many things, but coronary artery disease is the common intervention being done. Now, other than electrophysiology, the subspecialty coming up is structural interventions. So structural intervention guys do this aortic valve replacement, mitral valve clips are being done, various other devices are being implanted. But yes, I think in our country, many of the coronary interventionists themselves
might do.
Train and do the valve interventions.
Also, there are something like proctors. What are proctors?
So whenever a new technology comes into being used, everybody needs to be trained. So whoever is going to do it, you need to be trained. And how do you train the people? And therefore, those who have done the original research, basic research, and through the animal labs and stuff like that, they are very well trained, and they are the first ones who start. So whenever a new procedure is being done, we call a trained person to help guide us how to do that procedure. So he will train us or guide us. So that's called a proctorship. So for most new interventions, if I were to start tower, for example, then I would call a proctor for 7, 8, 10 times, and by that time I will be trained enough to do it independently on my own. Okay. So the company also, with all these equipment, make an effort to get a proctor to help new people get trained into it.
How many structural interventionalists are there in Mumbai who deserve to be called that?
Just a couple of months back, there was an entire conference on structural interventions, and it was well attended by almost 350 people. That was all over the country. But I would say there are good 40, 50 interventionists in the city who are doing structural interventions.
So there are more structural interventions than there are arrhythmia or electrophysiologists.
Electrophysiology, unfortunately, yes, I think.
पैसा कम है क्या problem है?
I guess the number of patients with coronary artery disease are so many
Volumes are.
that even any DM or DNB cardiology fellow gets absorbed into private practice and gets burdened. Electrophysiology requires additional training of 2-3 years after finishing your DM cardiology. So, many youngsters don't necessarily, those who don't like the subject don't kind of.
But there is a shortage.
There is a shortage. So
of electrophysiologists.
Absolutely. So I think all over the country, we are just 150 of us managing a population of what?
150 crores.
Absolutely. So I think the number of electrophysiologists are definitely much less than what we need to have. And yeah, I guess there's a lot of effort being put to.
Okay, again, going back to TAVR, that is a transcatheter aortic valve replacement. I'm not going into details, but at least how many days stay and what is the cost?
So the cost does vary. The valve cost varies from 17, 18 lakhs to 25 lakhs.
Oh, wow.
And then the additional implantation cost. So the whole thing might be 25, 30 lakhs at least for the TAVR. The stay, it's just a 2-day stay required, because it's a non-surgical procedure, so to say, done through the femoral root transcatheter. So the procedure time also does not take much, 45 minutes to 1 hour. 1 day observation in the ICU is what might be required post-procedure. But yes, 2-night stay.
So if the patient or the family physician comes to him and says, my cardiologist has advised a TAVR and I'm 90 years old and I don't know whether I want to do it, should they encourage even a 90-year-old who's symptomatic, who has a reasonably good physical status to do TAVR? Should they encourage them for prolongation of life?
I think yes. So you will have to definitely individualize in terms of every person, because many of them are chronologically advanced in age, but biologically they are quite fit and active, and this might be their only limitation in terms of fainting or falling and having problems. So, and also those with LV dysfunction and aortic stenosis, it becomes a congestive failure, might become a real challenge, which you can't otherwise manage because of a mechanical problem. So I think TAVR is a reasonably good tool, good advancement in cardiology, and should be offered with a relative lower threshold, unless and until you have a lot of, you think that the overall medical problems of the person is going to limit his lifespan. Anyway, malignancy and stuff, other things, then you probably may not consider that. But otherwise, it's a good tool.
I think the family physician plays a great role in encouraging a patient who deserves, elderly patient especially, who deserves a TAVR, to push them if the expense is okay. Is there any cheap way to get a TAVR done?
So as of now, no. I mean, there is one Indian valve which has being manufactured. So that's at a cheaper cost. So that's at the lower spectrum of 15 to 17 lakh, the cost being, but it's still fairly high for many of our patients. So it's something which, as time goes by and as we have more interventions being done, the cost is gradually coming down over the years.
Does medical insurance cover that, you think? If there is an adequate cover?
So if they have adequate cover, it does cover.
Okay.
If they have adequate cover, it does cover. But yes, this is not very common to get the entire amount from insurance.
So one thing that I have started encouraging my patients who can afford a premium is to start increasing their medical insurance, because they are expected to live long now. And the longer they live, the more ICDs, pacemakers, CRTs, valves will they need. And therefore the expenses can be prohibitive, and hence insurance can help. Okay, that takes me to the arrhythmias, which are also equally important. Atrial fibrillation and SVT are the two topics that I would like to discuss with you. A little brief about what is supraventricular tachycardia.
So supraventricular, by the name it suggests anything coming above the ventricle. So in the atrium. So in the atrium, if you have the sinus node, you have a sinus rate which is going to be in the range of 50 to 100 as being normal, and with exertion it could be 120, 130. Now, the electrical impulse is supposed to start only from the sinus node, but many unfortunate people, the electrical impulse gets generated from other than the sinus node region. Or some people have extra electric connections in their AV nodal area. So these are the people who will develop atrial tachycardia, atrial flutter, atrial fibrillation, and even the paroxysmal supraventricular tachycardia, which we call. So generally we kind of the supraventricular tachycardia, we categorize them into two varieties. One is what we call as AV node dependent variety of an SVT, and the other is AV node independent variety of SVT. So for a clinician, it becomes very important. If you have a regular abrupt onset palpitation and then you do carotid massage or any of the vagal maneuvers and it terminates the tachycardia, these are AV nodal dependent variety of SVTs. These are the ones where there is an extra connection in the form of a WPW pattern or syndrome pre-excitation, or extra connection in the AV node region. So between the atrium and ventricle, see, the atrium and ventricle is actually insulated electrically by a fibrous ring, except for the AV node, which in an organized manner allows electric current from the atrium to come to the ventricle, and there is a physiological AV nodal delay. That electrical connection is a delay. So the atrium contracts first, empties the blood, and then comes to the ventricle. So in the AV nodal region, if you have an extra electric connection, that leads to an AV node reentrant tachycardia, or the fibrous ring is breached by an additional muscle tissue, that leads to X-ray pathway. That's a pre-excitation. That's a WPW syndrome. So these are the paroxysmal variety of SVTs, AV nodal dependent. So you block the AV node, the tachycardia terminates. So you do vagal maneuvers, adenosine, calcium channel blockers, beta blockers, the tachycardia terminates. As opposed to other supraventricular tachycardias, meaning thereby atrial tachycardia, atrial flutter, atrial fibrillation. So their origin is completely in the atrium. In the atrium, an atrial tachycardia may start from 140, 150 beats a minute to 250 beats a minute. Atrial flutter is an electric circuit within the atrium. Atrial fibrillation arises because most often of extra electric impulses coming from the pulmonary vein to the left atrial area. Pulmonary vein also actually has a muscle tissue. From the left atrium, the pulmonary vein has a muscle tissue, from the atrium extending to the pulmonary vein. And that is the source where extra electric connections develop. They fire randomly, rapidly, 350, 400 beats a minute, and lead to atrial fibrillation. So all these are AV node independent variety of SVTs, where despite giving AV nodal blocking drugs, the atrial arrhythmia will continue, but it will control the ventricular rate. It will not cure you of the arrhythmia per se. They will require specific antiarrhythmic drugs. So this is in brief about the SVT.
So first, let us talk about the AV nodal dependent SVT. This is commonly presenting to you as somebody who has sudden onset of palpitations and probably sudden abrupt offset also.
Yes.
Sudden
So
onset, sudden offset.
absolutely. So sudden onset and sudden offset. So in history taking, it's very important to be able to differentiate whether this variety is something which is benign and which has a long-term benign outcome and a potential permanent solution. Sudden onset, rapid, regular palpitations, and abrupt stopping of palpitation, that would mean that it is AV node dependent variety of arrhythmia.
And this is the kind of arrhythmia that you may give the vagal maneuvers like Valsalva or carotid massage. Should they give vagal maneuvers in a patient who presents with this? They do an ECG, the ECG shows SVT. Should they do vagal maneuvers or not?
You should. I think you should. It's important. I think simple vagal maneuvers, so we teach the patients also that, at home you can do vigorous coughing, you can strain as if you are constipated, you can swallow a cube of ice, retching, those maneuvers you can do. In the clinic, what you should do more is carotid massage. Carotid massage a patient should not do on his own, and you also should be a little careful about the carotid massage. In elderly people, what we are worried about is that they should not have atherosclerotic carotid artery disease, where you keep on massaging and you have a bad outcome. So you feel the carotid pulse. If there is no thrill, if there is no bruit, then doing a carotid massage is safe. Doing it on one side at a time and learn the technique properly at the jaw level, feel the carotid pulse, use a thumb and massage it 15-20 seconds, with a firm pressure. They have a little bit of discomfort at that point in time. That's the way you do it. And then if it doesn't terminate, then you can do it on the opposite side. And
So you can repeat it how many times?
so I would think that you can try a couple of times. If it works within that time, well and good. But sometimes in some people, what happens is it is the pain or discomfort which increases the sympathetic drive, and then the tachycardia does not terminate. Those are the ones, unfortunately, will require medications.
So when he said at home, that means this kind of supraventricular tachycardia can recur, keep on recurring periodically, and therefore the patient may be taught some maneuvers, vagal maneuvers that they can do. Can you repeat the vagal maneuvers taught to the patient?
So generally, the simplest thing is to tell them to cough vigorously. When they do coughing vigorously, it is training, and that increases the vagal tone, vagal drive. The other thing is to retch, to let them put fingers deep into their throat as if they want to retch or vomit out. That's the second thing they do. Third is to strain as if want to pass motions, and then strain for some time and suddenly relieve, strain and relieve. So that's the third thing we tell. And the fourth is swallowing of ice cubes. Ice cube swallowing also can lead to a vagal phenomenon, simulation, and it can terminate the tachycardia. In young children, pediatricians, they do is the eyeball massage, but that again, like a carotid massage, is restricted to the medical person.
Okay, so that is, so if a patient has SVT and they document it maybe on ECG and they need now to refer to you, when will they refer, or when will they medically manage the SVT on their own with drugs like calcium channel blockers? Is it possible for the GP to manage SVT?
Yeah, it is simple. So it's a common problem, a relatively common problem. The incidence is 1 in 2 to 3,000 people have these paroxysmal supraventricular tachycardia. So there are a large number of patients. So when you have such a patient who have this abrupt onset and offset, I think the most important thing is to come to a diagnosis. Unfortunately, we have had so many instances, because when they come to you, their palpitation probably has stopped. And they are just giving you a history. The doctor had suddenly this. You examine, you do ECG, you even do 2D echo, everything turns out to be normal. And sometimes, we mistake them as anxiety, stress, especially young people, exam going, this, that. We have had, unfortunately, few situations where they've been labeled as neurotics, and they eventually turned out to have SVT. On one fine day, it lasted long enough for them to go to the hospital or to come to you, and you see that the pulse is very high. So have a high index of suspicion when you have abrupt onset and abrupt offset of palpitations. So if you have documented an SVT, depending on the frequency of the SVT, you may decide on giving a medical treatment. So if it's a first episode, you may virtually do nothing, especially if there are no other comorbidities. So that is another important thing. If this is an elderly person who has got hypertension, who has got structural heart disease, LV dysfunction, something like that, then you have to be more aggressive in terms of treatment. But young people, otherwise normal, first episode of SVT, you may do nothing, just guide them. That next time when they happen, either they record an ECG, make sure that this is a pattern they have, or if the episodes are frequent, then AV nodal blocking drugs. Calcium channel blockers are most frequently used, either verapamil or diltiazem, and sometimes even beta blockers. So these are the first line of drug that is often used in these people with SVTs. If you have recurrent SVTs, or if you have, despite the drug therapy, or you have significant symptoms associated with SVT, especially some of them 180 rate or more, and they have syncope, then probably you should be more worried. If on the ECG you have picked up a WPW pre-excitation pattern, then you don't wait, then you don't conserve these patients, then you refer to us and we need to sort it out. Because some of the WPW patterns, they may, vast majority present with SVT, but some may have sudden death.
So WPW, Wolf, Parkinson, White has what features on which they can recognize on ECG?
So I think ECG is a very important tool. So I hope and presume that many of you are doing ECGs in your clinic. In an ECG, when you see a QRS which is wide, then you look at the PR interval, and the PR interval is short. And then you try to look at what is the width of the QRS due to, and you'll realize that there is a slur in the upstroke or the downstroke of the QRS after the P wave ends, that would mean this is a delta wave. And this is classic pattern of a pre-excitation or WPW pattern.
We'll send you some ECGs of SVTs and WPW syndromes on the group. I don't think many of them do ECGs. Can you raise your hands who do ECGs in their clinic? I'm wrong, not bad. And how many of you would like to do ECGs and not doing yet? Okay, so there are more. So
I think it needs to be encouraged. So all of you should have an ECG machine, should learn the ECG, because you all do home visits also. So at that time also picking up infarcts or stuff like that, these arrhythmias, very important. In fact, so we probably went through this, but you know, how many of you are aware of AEDs? What is an AED? Yes, automated external defibrillator. So in a sudden cardiac arrest victim, when you do your CPR, you need to call for a defibrillator, and that helps to save lives. So this is something which is becoming more common. And that's where I would think that if you have a better clinic, if you have a clinic which serves many patients, if you have a society which you are having AEDs in place, in addition to the ECG, AED is the next thing that is happening that you need to have more and more frequently.
Yeah, we'll come to AED also, because this is an area that we have discussed on our forum also. And ECGs, I think I'll take a promise from him also that next year, 2024, we dedicate part of the teaching to ECG. And we hope that there will be some contribution by you to whoever wants to learn ECGs. Of course, there are many forums that teach ECGs, plentiful YouTube channels and websites for teaching. But maybe we can do some practical training of interpreting ECGs. We were on SVT. So you said that if the SVT is recurrent or associated with long episodes, syncopal episodes, you may have to intervene when drugs are not alone sufficient. And that intervention is something called radiofrequency ablation?
Yeah, absolutely. So all the AV node dependent variety of SVTs, the radiofrequency ablation has a very high cure rate, almost 98-99%. All the AV node reentrant tachycardia, as we call it, extra connection besides the AV node, or the WPW, Wolf Parkinson White variety, they have a very high chance of a permanent cure. So by this technique, it's a non-surgical in the cath lab. Patient is awake by the groin. We put in small little electrode catheters inside the heart, and essentially it's taking an ECG from inside the heart. These catheters will do that. Once we take ECG from inside, two things we understand. One is, are there any extra connections? So that's what we pick up from the EGMs. And the second is, we can start the tachycardia, initiate the tachycardia.
Precipitate a problem.
Induce the tachycardia, correct. Precipitate the problem. Precipitating the problem helps us to identify the source with the help of these intracardiac catheters. And once we know the source, we go with these catheters at that area and deliver radiofrequency energy, which is nothing but endocardial cauterization. It's like a cautery. So the extra tissue is there. You heat up the tissue, destroy the electrical properties, and take care of it. So it's a very good tool for vast majority.
So electrophysiologists can cause a myocardial infarction with alcohol, cause an arrhythmia with, they're dangerous people. Okay, so you can cure this by a simple procedure, and therefore this is something that we should be aware of, and therefore refer such patients as soon as we think that the medications are not working. Radiofrequency ablation is also used in other things. So I'll just cover radiofrequency ablation.
Sure.
What other things can be ablated?
So the success rates are highest with this AV node dependent variety, but the AV node independent variety, atrial tachycardia, atrial flutter, atrial fibrillation, those are the other arrhythmias where radiofrequency ablation can be done. The success rate might be a little lower, in the range of 90 to 95%. The atrial tachycardia and atrial flutter still have a very defined electrical circuit abnormality, and they are much easier to ablate. Atrial fibrillation is a big challenge. There is a lot of advancements happening in AF ablation also, because now you have to go to the pulmonary veins, the 4 pulmonary veins, common source, and we need to electrically isolate the pulmonary veins from the rest of the atrium. a little laborious procedure, has its own little bit of risks also. So generally, ablation for atrial fibrillation is done for people who are drug resistant, who have failed at least 2 drugs. And then we offer them ablation for this. The ablation can also be done for ventricular tachycardia. So this is important to understand. And ventricular tachycardia can occur in people with structurally normal hearts or structurally abnormal hearts. The structurally normal hearts variety of ventricular tachycardia, in fact, occur in young people, and they behave very much like an SVT, paroxysmal onset, abrupt termination. And in fact, when young people have this and the ECG is recorded, the ventricular tachycardia is also misdiagnosed as SVT with aberrancy. And often what happens is that some of these VTs get terminated by beta blockers and calcium channel blockers. So their behavior, clinical behavior is also like an SVT. But these are the ones can be cured with radiofrequency ablation with a good success rate of 95% or so. So idiopathic VT, we call it. Idiopathic VT can be also treated with radiofrequency ablation.
So radiofrequency ablation and pacemaker implantation probably are the 2 commonest procedures done by electrophysiologists.
Yes.
The commonest.
Yes.
Okay. We will, before we go ahead, I think, how many of you are slightly toxic? Just raise your hands. Slightly. Yeah, quite a few, right? I'm very sorry about that. So in such situations, I will give them a poem so that they can relax a bit.
Absolutely. I'd like that.
बदले हुए वक्त की देखो सोच कितनी न्यारी है, बदले हुए वक्त की देखो सोच कितनी न्यारी है, दिल का बड़ा होना अब अमित कहते हैं बीमारी है। चमड़ी का रंग हो गोरा काला किसको पड़ी है दोस्तों, चमड़ी का रंग हो गोरा काला किसको पड़ी है दोस्तों, दमड़ी का रंग जो काला हो तो आपका पलड़ा भारी है। किसी किसी को छप्पर फाड़ के देता है ऊपर वाला, किसी किसी को छप्पर फाड़ के देता है ऊपर वाला, जिसके सर पर छप्पर नहीं है उसकी अब कब बारी है। और अहिंसा क्या है भूल गए हैं बापू माफ कर देना, ये पुतिन के राज में या इजराइल के मामले में अहिंसा क्या है भूल गए हैं बापू माफ कर देना, मुंबई में तो फ्रूट जूस का नाम भी मारा मारी है। So wake up and we go ahead. So we were discussing atrial fibrillation, and you said sometimes ablation not very successful in atrial fibrillation. Now, atrial fibrillation is another disease that is becoming more and more common as we grow older. The reason why it will be more common in the elderly is?
So again, it's a aging disorder.
Okay.
And people after 60, 65 years of age, the chance of developing atrial fibrillation becomes exponentially high. In fact, there is 1 in 4 individuals will develop atrial fibrillation after the age of 40 years.
Oh, 1 in 4.
That high. I think, in this.
Okay,
they're
checking the pulses. Don't do that, not yet.
So I think for the general practitioners, one of the most important things is opportunistic screening of your patients. So when the patients come to you, elderly patients, some cardiovascular risk factors, you should take their pulse. You too take their pulse. But if you find the irregularity, take the ECG and you kind of pick up the atrial fibrillation. So atrial fibrillation is an age-related phenomenon and also known to occur much more with certain risk factors. So we know hypertension, diabetes, but what we don't realize is obesity, sleep apnea, thyroid issues. All these things make the atrial fibrillation much more prone, even in a relatively younger patient population. So in our country, valvular heart disease is also not still gone. So we will see many patients having atrial fibrillation because of...
and mitral valve disease causes more atrial fibrillation than aortic valve disease. So why is atrial fibrillation bad?
So I think this is very important to understand that atrial fibrillation is bad. In fact, there had been a study done where they were comparing the symptoms because of atrial fibrillation and symptoms because of coronary artery disease, the quality of life score were much worse in the AFib group of patients than even with coronary artery disease. Because coronary artery disease, yes, you have exertional symptoms and you manage your exertion, you're probably relatively okay. But atrial fibrillation, resting symptoms, tachycardia, palpitations, shortness of breath, tired, fatigability, so they're much more symptomatic. Other than symptoms, the worst thing with atrial fibrillation is stroke, thromboembolism and stroke. That is very bad. So if you look at all strokes, if the neurologist also looks at all strokes, almost 20% of strokes are because of a atrial fibrillation leading to thromboembolic phenomenon. So it's a sizable number of population which we are having a burden with this complication of AF and thromboembolism. And eventually AF leads to heart failure related hospitalization. And both these things is much higher, such that if you have an individual with atrial fibrillation and individual with no atrial fibrillation, the survival is almost 10 years less in a patient who has atrial fibrillation as opposed to not having atrial fibrillation because of all these problems.
So atrial fibrillation can be picked up by the generalist fairly easily. Check the pulse. Sometimes the patients have smart watches which they can tell you that they have irregular heartbeat. Sometimes the atrial fibrillation is paroxysmal, meaning it comes, goes away, comes, goes away. How do you detect paroxysmal atrial fibrillation?
That is the major problem with atrial fibrillation. So once they are persistent or permanent varieties, pulse and ECG takes it. But many of them in the initial natural history will be paroxysmal episodes, intermittently happening. And therefore, it's very difficult to pick up by the physicians. And therefore, that is where we use a lot of these tools to be able to pick up atrial fibrillation. And Holter is one of the tool, Event Monitor is another tool. And the wearables themselves, so the Apple Watch itself is able to diagnose atrial fibrillation by the ECG which it gives fairly accurately. So I think the paroxysmal or intermittent variety, a high index of suspicion from the symptoms, and then doing these tests are the only ways in which we'll pick up.
And is paroxysmal as bad as chronic atrial fibrillation?
Yes, so this is the other part of the story, that if it is intermittent, we would think that, it's an intermittent problem, but that's not the case. As far as the stroke risk is concerned, the atrial fibrillation, whether it's paroxysmal, persistent or permanent variety, does not matter so much. It is the associated stroke risk factors which a person of atrial fibrillation has will determine the occurrence of stroke. So we have this scoring system, and you must have heard this CHAD-VAS score. So essentially, if you have an AF patient, but he has congestive failure, he has hypertension, he's aged more than 75 years, he's diabetic, he has a past history of stroke, he has vascular diseases. So all these risk factors, if they are present, whether you have intermittent or whether you have persistent does not matter. As long as the stroke risk factors are more, the chance of thromboembolism and stroke is going to be higher.
Again, to go back to the statement that we have already made, atrial fibrillation can be of two varieties. One is valvular or valvular atrial fibrillation, and one is non-valvular atrial fibrillation. Valvular atrial fibrillation is chiefly associated with mitral valve disease, like MS, MR. Non-valvular atrial fibrillation is those risk factors that he already mentioned, cardiomyopathy, ischemic heart disease, etc. Now, our job is, of course, to detect atrial fibrillation. Most of the times, once we detect atrial fibrillation, we will be referring the patient to a cardiologist. We will probably not be managing long term. Is that not right? Should we manage long term?
It needs to be managed. I mean, atrial fibrillation.
I mean, we mean generalist. Should a generalist always refer an atrial fibrillation to a cardiologist?
Yes, I think it would be definitely worthwhile to have a detailed opinion about his atrial fibrillation, whether it is a, one isolated episode, whether it is going to be a recurrent problem, what are the co-associated morbidities. All things need to be studied very well, because vast majority will have a lifetime requirement of medications and follow-up.
So the medications required by atrial fibrillation probably are of three varieties: to prevent strokes, meaning anticoagulation, to control the rhythm or the rate, which is another area, and maybe if there is failure, to treat the failure, heart failure. So these are the three. And I think that is difficult for us as generalists to probably monitor very well. What, however, we have to do is monitor the drugs that are being given to the patient for their side effects. That is our main job when an AF patient is being treated. Because cardiologists are busy. You give an appointment for the next time after how many months? So they are busy people, and we are faltu sitting in our clinic. Anybody can come, and we first come, first serve. We see them. So we are the people responsible for monitoring the patients, and I think you will have to tell us about each variety of drug and how to monitor. So which AF patients are on anticoagulation? All, if they are chronic?
So we would say that those who have a high CHAD-VAS score or those who are valvular disease. So those valvular disease AF patients definitely require anticoagulation. In the non-valvular group, we look at the CHAD-VAS scoring system, and those who have more risk factors, generally 2 or more risk factors, they will require anticoagulation. And in the non-valvular age group, adult age group, we generally use the NOACs or DOACs, the newer oral anticoagulants. I think everybody should be aware of them, because to improve the outcome of AF, stroke prevention is important. And for that, anticoagulation is important. Now, anticoagulation, fortunately, with the new drugs, we don't need much monitoring in terms of INR or blood testing. That is not required. Drug-drug food interaction not required. But it's not as simple as giving antihypertensive medication or anti-diabetic medication. Every 3 to 4 monthly, you should ask your patient with anticoagulation, keep a check on his hemoglobin, get a urine and stool test done, get a creatinine done, because these anticoagulant drugs can lead to bleeding. That is their major problem. If they lead to bleeding, internal bleeding is the reason why many of them require, again, hospitalization, stuff like that. So you need to preempt that. And the dabigatran, rivaroxaban, apixaban, these are the 3 drugs available. Dabigatran and rivaroxaban causes significant acid peptic symptoms, so they need to be in antacids, and you need to every 3 monthly. They are all renally cleared drugs. So if you have a rising creatinine, then again you need to lower the drug doses of these drugs, or sometimes even switch or change the drug. So that is where the anticoagulation will require a constant interview with your patients, that, how are his symptoms? Every 3, 4 monthly, do these tests. Make sure that it's not causing any side effects.
Okay. These are, as he said, the NOACs. NOAC stands for non-vitamin K oral anticoagulants, or they are also called novel oral anticoagulants, or whatever. There are multiple full forms of NOACs. But we should become aware of NOACs, because you will commonly see them in patients who are on polypharmacy. You will often see an apixaban, or that is called Eliquis, or rivaroxaban, etc. Prescription, and you should know what is happening there. The patient may be on aspirin also, and you should know what to monitor, what to ask the patient, maybe check their CBC or stool foracle blood sometimes. So that is something that you'll have to coordinate with the cardiologist and monitor. So these are NOACs. What about valvular atrial fibrillation, where warfarin or acetrom, as we call it, are given? What is their role?
So there the role is equally important. So all those who have either a metallic prosthetic valve and atrial fibrillation, or those who have significant mitral valve disease and then they have atrial fibrillation, again, in them you need to be on an anticoagulation. But here the vitamin K antagonists are required, which is warfarin or acetrom, and these drugs have a very narrow therapeutic index, as we call it. So a regular monitoring and check of INR is required. The INR should be checked on a monthly basis. This is what we need to enforce our patient, that every monthly they need to do INR. If there is any new drug that has been introduced, you need to understand that whether this drug will potentiate the action of anticoagulation or reduce the action. Maybe when you don't know, you will probably ask to do the INR more frequently when a change of drug therapy is there. Diet restrictions might be there. Suddenly having a lot of green leafy vegetables and then not having for many days, this will fluctuate the INR. The INR fluctuates even with the reagent that is available on a regular basis. So that's where it is important to maintain this therapeutic range of INR value between 2 and 3. INR normally should, in normal individuals not taking anticoagulation, should be around 1. And those who take the blood thinners, the vitamin K antagonists. There we want to keep the blood thin, but thin enough that the INR value will be between 2 and 3. Anything which is going above 3.5 and 4, the risk of bleeding will happen. Anything which is less than 2, the effect of the drug will be lost and the chance of stroke or thromboembolism will occur. So this is what we need to understand. Now, many of your well-to-do affording patients, literate patients, point of care anticoagulation, INR management is also available. So just like the blood glucose test, you have this INR strips available, which they can do at home INR testing.
Is it? Okay.
And yeah, and that home INR testing is becoming more important, relevant.
It's a card test or requires a machine?
So it requires a machine. You just a pin prick, and that strip is inserted into that machine, and you get a INR reading, and it's fairly accurate.
And expense?
So the machine is almost 40,000 rupees, and every strip also costs a couple of hundred. But I think that's where
worthwhile. Okay. So one is anticoagulants. The second group of drugs that we use is antiarrhythmics. Now, cardiologists have learned over time that in a chronic atrial fibrillation, converting the atrial fibrillation to sinus rhythm, which is difficult through ablation or through shocks, while controlling the rate from say 160, 200, 350 to a better rate. Rate control probably has equal prognostic improvement as rhythm control. Am I making a correct statement?
Yeah. So in atrial fibrillation, we want to, either get them into normal rhythm, this is called a rhythm control strategy, or control their ventricular rate. You don't want the ventricular rate, palpitations, tachycardia going on frequently. So rate control or rhythm control, these are the two drug strategies for symptom improvement overall. And it has been studied that rate and rhythm control, both strategies work equally well in terms of patient benefit if the patient is taking anticoagulation properly. I think that is important, whether it's rhythm control. The problem is what many times in rhythm control, a patient is given antiarrhythmic drugs, he comes into sinus rhythm. When he comes into sinus rhythm, the anticoagulation is stopped. That you cannot do because the rhythm control cannot be guaranteed. What is sinus rhythm today may not remain sinus rhythm despite the drugs in the next few days or weeks or years. So both of them, rate or rhythm control strategy, require the anticoagulation, and then choosing either of the drug is good enough. Rhythm control is something which you should always think of as the first default strategy, especially in young patients, relatively young patients, because with the fibrillation, they become very symptomatic. And if you address them in the early stages when the heart is otherwise structurally and functionally not too abnormal, then there are long-term benefits of a rhythm control strategy. But in the elderly group, restricted activity, then a rate control drug, getting the ventricular rate. So what is a controlled ventricular rate? Anything which is less than 110 is a controlled ventricular rate. Not to worry, not to bother. 70 to 110, the rate fluctuates at rest. With exercise, it may go to 110, 120. That is acceptable.
Again, I'm repeating that we are all tired, understood, but 10 minutes more of absolute attention, a few very quick pointers so that afterwards we'll be posting these videos and we'll be posting our information on the group, which does not mean you sleep now, you keep awake. And just last few things that we will, because there are many areas that he can cover and he has done already several areas very, very well. Cordron, or amiodarone, is a drug often used for heart, for atrial fibrillation. Amiodarone does both rate control and rhythm control?
It does both, rate control and rhythm control, both. So it controls the ventricular rate, slows down the rate, but amiodarone should not be a drug used for rate control. If you're using amiodarone, then you should hope and achieve sinus rhythm control. That is very important. So that's where amiodarone is one of the most abused drugs, I would say. Any irregularity in the pulse, any ventricular ectopy, any atrial fibrillation, amiodarone is there, and then it gets continued for long time. And unfortunately, long-term side effects are very high. Thyroid dysfunction tend to happen between 10 to 20% of patients. Long-term amiodarone can lead to lung fibrosis, skin pigmentation. So I think one has to be a little careful when amiodarone is being given, because we find amiodarone being abused a lot, overused a lot. It is a strong drug, and one of our teachers, Dr. Kale, used to tell us that, many of the SVTs are like cockroaches. For a cockroach, don't use an atom bomb.
They survive an atom bomb, they say. Okay. So very important for the generalist. Very, very important. You will see many patients on amiodarone. These patients will have atrial fibrillation, chronic atrial fibrillation. You will see that their atrial fibrillation continues as atrial fibrillation and their amiodarone continues. And this is when you will have to interact with the cardiologist and tell them, okay, the TSH has become 125, the eye has developed corneal deposits, the lung is showing fibrosis. Can we withdraw amiodarone? And most of the times, amiodarone is actually useless, and rate control requires other drugs, and rhythm control is not happening. And that is when, so I think amiodarone overuse, because amiodarone has so many CYP-related drug interactions, which, it can be with atorvastatin, for example, another cardiac drug. We have to control the use of, so it is the rate of amiodarone control is important for the GP. Okay, so that, of course, you will have to interact with you can't withdraw amiodarone on your own. You will have to interact with the physician. Okay, very quick questions. Implantable cardioverter devices was one device you spoke about. ICD, as he said, are principally used for preventing tachyarrhythmias, VTAC-related certain cardiac death, but also have a pacing function. There are pacemakers, which are for bradyarrhythmias. What are the symptoms with which the GP will see a patient who requires a pacemaker?
So bradycardia pacemakers, as you would realize for bradycardia, the bradycardia could be either sinus bradycardia, so sinus node dysfunction, or it could be an AV block. Now, AV block is very dangerous. So therefore, whenever a person has bradycardia, he might complain of tired, fatigued feeling, but pre-syncope, syncope, those things happening, you should take an ECG. In the ECG, if there is an AV block, that becomes almost an emergency situation to get him into the hospital and see to it that he gets a pacemaker, because AV block can be malignant. AV block are the ones which can lead to sudden death, especially when the heart rate is less than 40, if the QRS is very wide, if he's already had a syncopal event. All these things tend to happen in the elderly age group as a degenerative conduction system problem. Sinus node dysfunction and sinus bradycardia, less malignant, may also require pacemaker. So sinus node dysfunction manifests as a tachybrady syndrome or a pure bradycardia. Pure bradycardia would be sinus bradycardia, junctional rhythm, heart rate less than 40, same symptoms of tired, fatigued, breathless, giddy, pre-syncope kind of a feeling. And some of these patients not only have sinus bradycardia and junctional escape, but they have, because of the bradycardia, there is an irritability of the atrial myocardium, wherein atrial tachycardia, atrial flutter, atrial fibrillation may also happen. So they yo-yo between brady and tachy, and it becomes a medical challenge. How do you treat the tachy? If you treat the tachycardia, atrial flutter fibrillation with bradycardic drugs like amiodarone or any other beta blocker or calcium channel blocker, the rate will become inappropriately low. You can't manage that. For bradycardia, there is no drug. There is no medicine that can improve the bradycardia. Orsiprenalin, Orsibest is used as a default drug, but it's not a very effective drug by itself. So these patients who have this tachybrady problem because of sinus node dysfunction often land up with pacemaker, which will prevent the bradycardia, and then you can decide tachycardia what kind of treatment it requires.
So bradycardia will require the pacemaker, and tachyarrhythmia or tachycardia will require medications. And then medications can be given with, because we have safety of pacemaker in place. Costs of pacemaker implantation.
So the dual chamber pacemakers these days are 1.5 lakh at an average. Dual chamber becomes more physiological, where is a wire in the atrium and ventricle, so it will work and mimic like a normal PQRS complex. So it's a fairly standard procedure and very cost effective, I would say.
The third device that you place is something called CRT. What is CRT? We don't know anything about it.
So CRT pacemakers or defibrillators, CRT stands for cardiac resynchronization therapy. So this is used for patients with heart failure. So patients who have left ventricular systolic dysfunction, ejection fraction has become 35% or less. They have all the heart failure symptoms of tired, fatigued, breathless feeling, requiring hospitalization, requiring diuretics. Now they are on all drug therapy for their heart failure also. But despite the what we call now as 4 pillars of drug therapy in terms of heart failure, which is ACE inhibitors or ARB or ARNI, SGLT2 inhibitors, mineralocorticoid receptor antagonists, and beta blockers. All of them are there, but yet the LV systolic function is 35% or less. and if these patients have left bundle branch block on their ECG. So what happens with left bundle branch block and LV systolic dysfunction, they kind of is a vicious cycle worsening each other. Because of the left bundle branch block, there is a delayed contraction of the left ventricle. The left ventricle contraction occurs very late. So left ventricle sort of gets isolated and does not work in sync with the right ventricle or does not work in sync with the atrium. And that is which worsens the heart failure. And that is where we put this cardiac resynchronization pacemaker, wherein not only the two leads in the atrium and ventricle will be there, but there will be a third lead going into the left ventricle. And we access the left ventricle via the coronary sinus. So through the coronary sinus into the cardiac vein, we'll put another lead. So now we can, control the electrical activation of all the atrium and both the ventricular chambers. Because we can control it, we can time it. We can negate the left bundle branch block. We can electrically activate the left ventricle early and synchronize with the right ventricle in the atrium. And that's why it's called a cardiac resynchronization therapy. It helps to improve the ejection fraction. So that will improve the ejection fraction from 30-35 going to 40-45 or even normal.
So here there are many people whose parents, relatives or themselves have an ejection fraction due to previous myocardial infarction of 35% or less. Many people with relatives like that. Should all of them be referred to for CRT if they have symptoms?
So I think we need to look at as I said, for the improvement of the LV function, we need to have LBBB. So if they have LBBB, wide QRS width is more than 150 millisecond, then CRT will benefit them. But if they have narrow QRS, not LBBB type, QRS is just about 120, 130 millisecond, CRT is not going to improve their pumping function. But there you have to think whether they will benefit from an ICD, because they are also, all those people with ejection fraction 30% or less are at risk of sudden death. So we need to decide about ICD.
What is the cost of CRT?
So CRT pacemakers are roughly 3.5 lakhs or so.
Okay. There are a couple of few more topics left, but I think we will stop here. Thank you, Amit, and we will hope to do one more thing with you. If you get time, sometime I'll come to your place and we'll do a few video recordings of the topics that we have not done today, so that it might be completion of the areas. Is that okay?
Absolutely.
We'll give him a big hand, please.
My pleasure. Thank you. Thank you.
I'm sorry that I could not take Q&As from you, but what we will do is I would open our chat for queries on this topic. We would like you to put your queries and I will be going to his place, recording a video again and putting it up on this. Thank you again, and 10-minute break. Thank you. You will be called upon if needed to reinforce the teams. Also, Dr. Uday Thakre here, Dr. Neha Shah here. She's there? Okay. And Dr. Archana Vinarkar. Is Dr. Archana Vinarkar here? Dr. Devesh Desai? Not here. Okay. So, fair enough. Dr. Mukesh Bhamre and Dr. Kumar. Dr. Kumar will captain team A, sit on that seat, and Dr. Mukesh Bhamre will sit on this seat. Okay. अशर साहब, बाहर कितने लोग खड़े हैं उनसे 10-10 रुपए लेके अंदर भेजिए. बाहर कितने लोग खड़े हैं, जल्दी जाइए, देखिए और बाहर से निकालिए अंदर. सर अंदर आने तो दीजिए. हाँ, ये इस साल लेडीज, इस संडे को लेडीज का दिन है, नेक्स्ट संडे को जेंट्स का दिन आएगा. ओके, दिस इज हाउ द क्विज वर्क्स. हाँ जी, हाँ जी, हाँ जी. Can I check the PPT once very quickly? स्लो रिस्पॉन्स है. हाँ, स्लाइटली हार्ड प्रेस. ओके, हार्ड प्रेस. या
जो होगा देखा. इट्स ओके. मेरे को उसका नर्व्स मालूम है.
Desh, you are a reserve for this one. So I have now, how many reserves do I have? No, I'll call you up. 5 reserves. Archana Vinarkar is here? Archana is not here still. Okay, so we have currently Anita Sardal, Uday Thakre, Neha Shah and Devesh Desai as reserve team members. We'll tell you what the reserves are for. Okay, so this is how the quiz works. Everybody settle down. Give them a big hand, the 2 teams. Now ask them, why were they given the privilege of coming without asking others? Yeah, we'll rectify that. But they were the first to register for the quiz, and hence, and I have to thank Dr. Rajani for helping me force them to come up here. So 3 members per team to begin with. Team A, captained by Dr. N.K. Kumar. Team B, captained by Dr. Mukesh Bhamre. Both these captains are not going to help them answer questions, but they will be asked a question separately which is not set by them, because most of the questions are set by them, and they will add to the points of the respective teams. Team A will go first. There are 10 topics, 4 questions on each topic related to neurology. Each set has 4 questions and only will be answered by one team. So first set team A, second set team B, etc. There will be no pass-ons. There will be no answering from the audience. It's a big request, because this is a very competitive quiz and these are very competitive people. They will come down and kill you if you answer for them. They are that competitive, okay? And yeah, that's how it will work. So, and the housing ticket, bingo tickets that are being given to you are irrelevant for this quiz. They will become relevant after this quiz ends, where we will play a neurology bingo. They are just being given to you so that you can do something to fiddle with your hands. Otherwise, they have no current purpose. Okay, so we start the neurology quiz with team A. Team A, you have a mic. You are team A. That is team B. There is a label there which you can't see, which says team A. Team B, you can see that label, team B. Yes. Team A. Team A goes first, 4 questions to team A, and there is no timer, but we will decide how much time you get. You don't get too much time. If you give 3 answers for 3 ladies, we can't take all 3. So you decide between yourself which answer is to be told. The first answer that comes into the mic will be considered your answer. Right? Again, no pass-ons. You will not be given a chance to answer their wrong answers. So please refrain. We will be asking the audience for the correct answer. We are set for the first topic of the day, which is cranial mononeuropathies, which a family physician will not infrequently encounter. Your first question. Is sudden sensory neural hearing loss, if idiopathic, unilateral or bilateral? Team A has to answer. Unilateral or bilateral? In the mic, please. Because we have a recording going on here.
Unilateral.
Unilateral is the correct answer. 10 points to team A. Sudden sensory neural hearing loss is something that you will see in your clinic. Patient will come with sudden, complete loss of hearing in 1 ear. Occasionally the loss is over hours or days, but usually sudden. Sometimes they don't even realize it till they put the phone on their ear. And this is a very important area where they have to be given. Second question. What is the drug of choice? What is the drug of choice in SSHL, and what is its ideal route of administration?
Intravenous steroids?
I will give them 5 points for half correct answer. The ideal route of administration, anybody?
IV.
Oral or intratympanic. Or both is the ideal route of administration. IV is rarely given unless usually the patient can tolerate oral. And you must give steroids within the first 3 weeks, first 2 weeks actually, to ensure significant regainment. So whenever a patient comes with you with sudden loss, first there will be an ENT evaluation that there is no underlying pathology of the inner ear, brain or middle ear, and this patient will be referred for steroid therapy immediately. So that is 5 points. So that was 10 for the first answer, 5 for the next answer. This is your answer. Team A continues. Name 2 more cranial mononeuropathies where steroids are the treatment of choice. On the mic, please.
Facial and optic, no, both neuritis.
Optic neuritis and you meant Bell's palsy, I suppose.
Palsy, yeah.
Bell's palsy, I'll give it to them. Optic neuritis and Bell's palsy. 10 points again to this. Now there are multiple cranial mononeuropathies that are treated with steroids. Most common in practice is of course Bell's palsy, where you give oral steroids. Some people also give antiviral drugs which have less evidence for them. Steroids are the most important thing. In Bell's palsy, the most important thing is to start steroids early, ideally within 48 hours to have best benefit. And the other disease is vestibular neuronitis, which we will talk about later. Fourth question to you. Amaurosis fugax is a sudden monoocular vision loss of 2 to 30 minutes, often described as a curtain coming down in front of the eye. This is due to an artery-to-artery embolism. Typically, where does the thrombus originate? Where is the occlusion? Which large vessel is? Give a very specific answer.
Carotid artery?
There are multiple carotid arteries.
Okay.
Give a very specific.
Internal carotid
Internal
artery.
carotid artery is the correct answer. 10 points again to them. Now this is another disease that the family physician has to recognize. Otherwise it goes unnoticed because it is a transient problem. The patient will come to you, I had a visual loss, partial in one eye. And it was like a curtain falling down upon my eye. And this patient probably is what we call amaurosis fugax. You must do a very aggressive investigation, including probably a CT angio. Once you do a CT angio of the brain, you will find that there is a tight internal carotid artery stenosis. These patients with amaurosis fugax means transient loss of vision. Amaurosis fugax, they may require urgent stenting of the internal carotid artery. So this is one area which you should not miss, lest they get a new stroke thereafter. Okay, so that is how many points? 35 points to team A, big round of applause. And let us see if they can add 10 points through Dr. Kumar. Dr. Kumar ko mic denge. Dr. Kumar, your question. Trigeminal neuralgia is classically not associated with any neurologic deficit, meaning they have no masseter muscle palsy or no sensory loss, etc. If there is a facial sensory loss in a case which sounds like trigeminal neuralgia, what do you suspect?
Say an acoustic neuroma.
Trigeminal neuralgia is the presentation, meaning sharp, multiple pains.
You are having facial.
Huh?
You are having, along with that, no, I didn't get
sensory loss and symptoms of neuralgia, which doesn't happen in acoustic neuroma. You get very sharp pains and you get sensory loss. Now what do you suspect? The condition is basically trigeminal neuralgia, but now this time with loss of sensation on the face. What do you suspect?
Multiple sclerosis.
Is the correct answer. 10 points to Dr. Kumar, multiple sclerosis. So that makes their total points how much? 45 points to team A. We go on to the second round. And this round is on migraine variants. Your question, first question. -2, -1, 1, +1, +2, +3 days. This is a very specific clue to a variant of migraine. Name the variant.
You're talking about the major and minor carotid. So it is 3 days, no? Variant of migraine. -2, -1, migraine variant one side.
Okay, we will give it to the audience. Menstrual migraine or pure menstrual migraine, it is called. So pure menstrual migraine is defined as migraine that starts on -2 day, -1 day, continues, +1, there is no 0 in this equation, +1 the first day of menstruation up to +3. So this is the 5 days of migraine to label the condition as pure menstrual migraine, correct? So that in this case, the prophylaxis required is just for a few days of naproxen, for example, started on -3 days. So we give naproxen from -3 days onwards for 4 or 5 days, and you may be able to prevent, instead of giving beta blockers every day or some such drug every day. Okay, so no points there for you. This was pure menstrual migraine. One migraine variant that occurs in children is named after a book by Lewis Carroll because macropsia, micropsia, and metamorphopsia are features of this variant. What book am I referring to?
Alice in Wonderland.
Alice in Wonderland syndrome is the name given to the migraine variant. And this is what is, say, a form of metamorphopsia where a person looks either taller or wider or smaller. Macropsia. This is a variant of migraine that typically occurs in children. It is not common, but if a child says that he has this, then you should not say that the child is faking for not going to school, etc. Okay, 10 points there for you. Next question. CVS is an abbreviation used for a migraine variant that presents with recurrent episodes of vomiting. What is the full form of CVS? Recurrent episodes of vomiting. Yeah, please give your answer.
Central vomiting syndrome, which I
Central vomiting syndrome, slightly incorrect. Anybody? Cyclic vomiting syndrome. We will give them 5 points for that. Cyclic vomiting syndrome is a migraine variant. Now, this is one variant, again, occurring more commonly in children that you should be able to recognize. Patient comes with episodes of vomiting, vomiting that lasts one day, few hours, goes away completely, comes back, goes away completely without headache. Even then, you have to think of migraine as a possibility. There is another migraine called abdominal migraine, where pain is an important component. Abdominal pain is an important component of the migraine. But cyclic vomiting syndrome has just vomiting, which keeps on occurring on a periodic basis. And remember, the drugs used for prophylaxis are similar to the drugs used in common migraine. Okay. Last question. Which fairly common variant of migraine is often referred to an ENT specialist and can be mistaken for benign paroxysmal positional vertigo?
migraine with vertigo,
Also known as
vestibular.
vestibular migraine. 10 points to them. Vestibular migraine. Now, this is something that we often miss. BPPV comes with, positional giddiness, and we must remember that BPPV-like symptoms without headache can occur in something called vestibular migraine. Vestibular migraine is a distinct entity within migraine which can occur with headaches or without headaches. These patients can have classic migraine episodes interspersed with classic vertigo episodes, or they can have headache with vertigo concomitantly. So it is sometimes difficult to, and therefore an ENT referral, check for nystagmus, maybe some other tests like nystagmometry may be done to be able to tell us that this is vestibular migraine. Otherwise, we will keep giving them drugs like beta-estine, etc., which may not be absolutely useful. And these, again, are prevented by giving beta blockers or sodium valproate, the standard preventive drugs for migraine. How many points do we have so far? 25 for you, and a special question to Dr. Mukesh Bhamre. We heard about pure menstrual migraine. What is MRM? What does MRM stand for? Related to pure menstrual migraine, and what does it mean? What is MRM? Again, related to pure menstrual migraine. Any guess? No guess? Anybody there? No pass-ons.
Menstrual related migraine.
Okay, I will give it to him. Menstrually related migraine aided by the primary team. 10 points to them. Menstrually related migraine. Meaning what? Meaning the migraine is that where it goes around the period dates, -2, -1, etc. Plus the patient also has episodes in between in the cycle. This is called MRM, menstrually related migraine. How is it important? This migraine will require daily prophylaxis or SOS therapy, but daily prophylaxis may be required. Those who are not familiar with daily prophylaxis, what I mean is prophylaxis of migraine involves giving drugs on a regular daily basis. The commonest drugs used are sodium valproate, beta blockers, and topiramate, and of course some people also use Cybelium, etc. So these are the various drugs used for prophylaxis of migraine. How many total points?
Team B 35, Team A 45.
Correct. So we go back to Team A. This round is on ocular myasthenia gravis. Team A has to answer your first question. Which two symptoms are the typical presenting features of ocular myasthenia gravis? On the mic, please.
Ptosis and diplopia.
Ptosis and diplopia is perfect, 10 points to them. Ptosis and diplopia due to extraocular muscle palsy. Do you know what ptosis is due to? Which muscle?
Levator palpebra's.
Levator palpebra's, and diplopia is due to these 6 muscles, the recti and the obliques. Okay, so these are the two presenting features. Your second question. The ptosis of ocular myasthenia gravis may be enhanced by sustained upward gaze. Enhanced by sustained upward gaze. What clinical test can reduce ptosis temporarily?
Application of ice.
Ice application and closing the
Resting
eye
of the
can
eyes.
both reduce the ptosis. I'll just explain this again. A patient has ptosis, often unilateral, sometimes bilateral, sometimes alternating ptosis. And if a patient comes to you with ptosis, which is recent onset, if this is myasthenia, this ptosis will have something called fatigability. Meaning, you ask them to keep their eyes open for some time, and they will gradually, the eyelid will droop. That is precipitating a ptosis. And relieving a ptosis, you ask them to close their eyes, rest for some time, and then they will be able to open the eye, or apply ice on the muscle, on the levator palpebrae superioris, and then they will be easily be able to open the eye for some time. So that is correct. 10 more points to you. The blood test for AChR-AB and acetylcholine receptor antibody is a very specific test for ocular myasthenia gravis and other myasthenia gravis also, but is positive only in 50% of cases. If negative, what test will the neurologist do to confirm myasthenia gravis? To confirm,
Injecting neostigmine and then seeing if the patient feels better.
injection of pyridostigmine or neostigmine now not considered a test at all because it can cause complications. The correct test, anybody?
Tensilon.
Anti-musk antibodies are also not very specific for OMG. The confirmative test is, no, it is basically EMG with repetitive nerve stimulation. You do an EMG of the facial area and give repetitive nerve impulses. As you give repetitive nerve impulses, you identify fatigability of the muscle. And therefore, you confirm. This is a confirmatory test that a neurologist will do. Okay, last question. I'm so sorry. Answer aa gaya? I can always reframe the question. In patients of myasthenia gravis, fluoroquinolones aggravate myasthenia gravis. Which other group of drugs is contraindicated in myasthenia gravis patients, especially if hospitalized? Antibiotics I'm talking about. Which other group of antibiotics in hospitalized patients is other than fluoroquinolones? Can't make it so easy. Make a guess.
Macrolides.
Aminoglycosides was a better answer. So I'm so sorry. Aminoglycosides is the drug group to be completely avoided, gentamicin, amikacin, etc. in patients of myasthenia gravis. So, and the last question to Dr. Kumar. So we'll give the points together. The points are? For this question now, here 0 points. Last question. So I think they have 30, they have 20. Okay, Kumar, while ptosis is due to weakness of the levator palpebrae superioris, what muscle weakness can cause the symptom of lagophthalmos? Lack of thalamus means difficulty in closing the eye. Which muscle weakness in myasthenia will cause lack of thalamus?
Orbicularis or oculi.
Orbicularis oculi, 10 points to Kumar. And yeah, आप लोग सिर्फ कैप्टन के पर ताली मत मारो. 30 points to, I think 30 points to team A, and we go on to the next round, the fourth round. The fourth round is on acute hypoglycemia. Why is this in neurology? Because acute hypoglycemia has three kinds of symptoms. One is sympathetic, like palpitations, tremulousness. The other is parasympathetic, like hunger. And the third is neuroglycopenic symptoms. Three groups of symptoms of hypoglycemia. Neuroglycopenic symptoms, where they become unconscious, they have slurring of speech. Some people can get focal neurological deficit like hemiplegia. Yeah. Now, your question. Which drug group can mask the sympathetic symptoms of acute hypoglycemia but not the parasympathetic and neuroglycopenic
Beta
symptoms?
blockers.
Beta blockers is the correct answer. 10 points to Taliyan ke saath, team B. Beta blockers can mask the sympathetic but not the parasympathetic. So the beta blocker patient will still have hunger and still become unconscious or have slurred speech. So you can recognize through those symptoms. Okay. Second question. Hypoglycemia that requires hospitalization will occur most commonly due to which one of these drugs? Insulin glargine, that is Lantus, regular insulin, Actrapid for example, and sulfonylureas, which requires hospitalization.
So insulin glargine.
Audience? Regular बोलता है वो लोग. और कौन है? Sulfonylureas. How many with sulfonylureas? Many. Yeah, that is the correct answer. So, ask the audience. Okay. So this is very important to know because as family physicians, we know that sulfonylureas are commonly given, especially glimepiride. We don't now use glipizide or glibenclamide, but glimepiride. Glimepiride is a long-acting drug. Hypo caused by glimepiride can last for 72 hours sometimes. And therefore, just giving one shot of dextrose in your clinic and sending them away is incorrect. You have to sometimes hospitalize the patient, especially if the sugar is 54 or below. Hospitalize. Do not hesitate. Hospitalize the patient. They will require dextrose, they will require drips, they will require repeated dextrose, sometimes they require other things. Let's come to the other things. Name one pharmacologic agent other than dextrose that can be injected to treat hypoglycemia.
Glucagon.
Glucagon is accepted. 3 drugs are used. Any 2 more? Anybody? Steroid.
So whether thiamine would be...
No, thiamine is given, but not for this. Diazoxide and octreotide. Octreotide and diazoxide are diazoxide is a drug that can be given subcute, just in case you can't get an IV line. And octreotide is a somatostatin analog, which can be used. Yeah, we will come to one more question related to that for the expert. Next question. What care has to be taken in patients to be treated for hypoglycemia due to prolonged religious fasting? You know, in Paryushan, for example, people fast for one month and then they come to a clinic with hypoglycemia. What precautions should you take?
To be treated for acute due to prolonged religious fasting.
You are giving dextrose to the patient, of course, but what other precautions should you take?
Electrolytes and thiamine.
2 answer diya hai. Okay, we'll give it to them. Thiamine is the correct answer that I wanted. We all think of giving thiamine in patients who come with hypoglycemia if they are alcoholic. That is a standard thought process. Alcoholic hai, must give thiamine. There are more situations where thiamine needs to be given. And one of them is after prolonged fasting. That is very, very important to give thiamine to such patients. Because fasting decreases thiamine B1 levels in blood. Dr. Bhambre sir, your question. Which of the three, octreotide, diazoxide, and glucagon, which of the three is most useful in refractory sulfonylurea-induced hypoglycemia? Sulfonylurea-induced hypoglycemia में ये तीन में सबसे अच्छा कौन सा है? Because they can keep this in their OPD if necessary. Glucagon, ये तीन में से
Glucagon.
is incorrect. Octreotide, glucagon actually is not to be given in sulfonylurea-induced hypoglycemia. In chronic alcoholics, you can't give glucagon because they don't have glycogen store, which is what breakdown happens with glucagon. You have to give octreotide, which acts very rapidly, which can be even subcute, and which you can keep in your clinic as a 300 rupee injection. So octreotide, Neo-Octide brand name, 50 micrograms, you can give subcute for persistent hypoglycemia related to sulfonylureas. Okay, so that is about the, how many points for this round, please?
Team B 30.
Okay, we have the both rounds, both ka
Yes.
score.
Team A 75, Team B 65.
Very close, so we will continue with the next round. Thrombolysis and acute stroke. Now, this is one area where the family physician has to become very, very proactive. You won't give thrombolysis, but you will decide about who to give thrombolysis to. So this is extremely important. And your first question. What is the maximum accepted time within which you can give altiplase or tenactiplase as thrombolytic agents in acute ischemic stroke? What is the maximum accepted window? Oh, sorry.
3.5.
3.5 hours.
Yes, hours.
4 hours.
Yeah.
You can increase the range. I said maximum window. If it is 3.5 hours, it is incorrect. What is the correct answer? 4.5 hours is the maximum window of period that you can give. In the US, 3 hours is accepted as the maximum time. In Europe and in India, we consider 4.5 hours to be the maximum time after a stroke when we can give thrombolytic therapy with two drugs. That is, one is RTPA, that is tissue plasminogen, recombinant tissue plasminogen activator, which is altiplase or Actylise brand name, and the other is tenactiplase, which is a plasminogen activator. Multiple brands are available. Tenactiplase being cheaper than altiplase. Your question, team. Question 2 to team. In wake-up stroke, I'm modifying this question because the simpler question is being given to you. In wake-up stroke, if MRI is unavailable to determine the time of the stroke, what is the time taken? Suppose the patient has slept at 2 a.m. and woken up at 8 a.m. and has not woken up in between or walked to the bathroom in between. You need to know 4.5 hours hua hai ki nahi hua hai. What time is taken as the onset of stroke time in a patient who wakes up with a stroke? What is the time of onset of stroke? If the patient has woken up with a hemiplegia, for example, how do you know what was the time of onset? Because the patient can't tell you. Stroke happened in sleep. MRI unavailable है अभी, आपको डिसाइड करना है फ्रॉम हिस्ट्री. रिलेटिव बोलेंगे इतने बजे सोया था, इतने बजे बाथरूम के लिए उठा था, बराबर उठा था, फिर वापस सोया था. आपको कौन सा टाइम लेना है? इन बिटवीन द स्लीप, शुरुआत ऑफ स्लीप, एग्जैक्टली वेकअप टाइम ऑफ स्ट्रोक, कौन सा लेना है? यू अंडरस्टैंड? यू नीड टू नो व्हाई, बिकॉज यू नीड टू नो 4.5 hours हुआ कि नहीं हुआ. वेकअप स्ट्रोक के साथ हुआ तो स्ट्रोक का ऑनसेट टाइम क्या सोचने का? वेकअप का टाइम सोचने का, सोने का टाइम सोचने का, बीच का मध्यम एवरेज लेने का?
Wake up time?
Is incorrect. Anybody? The last time he was seen going to bed after washroom or in the night, that has to be taken as the duration. So suppose the patient's wife saw the patient go to the bathroom at 3 o'clock and came back, and the patient woke up at 6 o'clock, then you know that it's a 3-hour stroke time, and you may give thrombolysis. But sometimes you don't know. So when you don't know, the question now is to Kumar. When you don't know, come to the next one later, the expert question. When you don't know, how will the MRI help determine the duration of the stroke? Mike, please.
Do a DWI and a flare imaging. DWI will be normal and flare will be abnormal depending on the 4.5-hour window period.
So can you repeat that? DWI stands for?
Diffusion weighted imaging, and flare is for, I don't know the full
Flare.
form of flare.
Okay. So what will, within 4.5 hours, what will DWI show?
DWI will show some changes in the MRI.
Correct.
And flare will be normal.
Correct.
If it is less than 4.5 hours. If it is more than 4.5 hours, both will
Both
be
will be
abnormal.
excellent. We won't go into technicalities, but I will show you a diagram. If you see here on the top, there are two images where there is a mismatch. The DWI is showing a faint white speck of what is called as diffusion abnormality, and that shows that there is an infarct there. But flare, which is done with another sequence of MRI, it is not showing the infarct. This is less than 4.5 hours. No, penumbra अलग आ जाता है. ये acute stroke है. And the lower one is where both images are showing infarct, and now that means diffusion and flare both showing. Now that means 4.5 4.5 hours chala gaya hai. For the GP, what is important of this? The importance is that if you have a wake-up stroke, hemiplegia, woken up with hemiplegia, you don't know. Patient slept at 12, nobody knows whether he went to the bathroom or not. He is aphasic, cannot tell you when he last went to the bathroom. You have to decide whether we can give thrombolysis or not. Send him to a center which has an MRI and let them do the evaluation through flare images and diffusion images, and they will be able to decide whether now the thrombolytic therapy will work or not. Okay. Just a little basic about thrombolytic therapy is this, that you must consider thrombolytic therapy in early strokes. It is a life-changing treatment in many patients. The downside is hemorrhage. Many patients who receive thrombolysis will have some intracranial bleed in the area of infarct. Now this downside is comparatively much lesser than the upside of surviving all their lives without a hemiplegia. So this is a very important thing to do. Even if you do have a stroke, God forbid, sometime in future, your first thing is go to the nearest stroke unit hospital and get evaluated for thrombolytic therapy. We'll be sending on WhatsApp, probably today itself, 10 commandments for the GP on strokes. Okay, next question, two pending to you here. In case of a stroke due to due to LVO, sorry, my mistake. Due to LVO, thrombolysis may fail and one may need to do mechanical thrombectomy. If LVO may L stands for large, what does VO stand for? क्या करें? What is LVO? Remember, thrombolysis has failed and we need to do endovascular mechanical.
Large vessel obstruction?
I'll give it to you. Large vessel occlusion, 10 points to you, and thank you for, you have to thank me. You're welcome. Large vessel occlusion. Can you name the large vessels? Can you name some large vessels whose occlusion may not respond to thrombolytic therapy? Some large vessels causing a stroke. Internal carotid artery, wonderful. Middle cerebral artery, as somebody said. Vertebral artery, basilar artery, which is formed by merger of two vertebrals, and the M1 segment of the first branch of middle cerebral artery is considered a large vessel. All these LVOs may require mechanical thrombectomy, either as an initial procedure, because if 4.5 hours have passed, or as a rescue procedure. You know how we do rescue angioplasty if thrombolysis has failed in a myocardial infarction? So as a rescue procedure. So if 4.5 hours have passed and there is a large vessel occlusion, then we can do mechanical thrombectomy for 24 hours. Correct? So that is the time limit that you have for mechanical thrombectomy. Okay, next and last question. On a home visit of a patient with acute right hemiplegia, you find the BP to be 170 by 105. Which BP medicine will you immediately give?
You don't give blood pressure medicines.
10 points to team D. Another important area, we panic, we give BP medication, sublingual nifedipine, labetalol, whatever. Please don't give BP medications in a case of stroke until the BP is 180, 110 or more. If it is 180, 110 or more, you are allowed to give an oral medication like amlodipine, fibrillation. Don't give sublingual anything. And you then send the patient. But often it is prudent to not give medication because any lowering of BP increases the infarct size. Okay, so that is how many points total to team A in the round 5?
30.
30 points to you, and let's go to round number 6. I have been pronouncing this name wrong all my life. What is the pronunciation? Okay, so the N is not silent. Why should the N be silent? N is both important. So it is not silent. Guillain-Barré, it's called Barré syndrome. Guillain-Barré syndrome. Okay, so the first time I'm using it like this. So let's talk about Guillain-Barré syndrome. Question 1. Is Guillain-Barré syndrome a lower motor neuron disease causing flaccid paralysis, meaning no deep tendon reflexes, no hypertonia, hypotonia, or an upper motor neuron lesion causes spastic paralysis with hypertonia?
Lower motor neuron.
It is a lower motor neuron with flaccid paralysis. I suppose you all know Guillain-Barré syndrome. Guillain-Barré presents with chiefly an ascending paralysis, ascending flaccid paralysis, ascending flaccid paralysis with hypotonia and loss of deep tendon reflexes, loss of Babinski response. The patient presents with difficulty in walking first, but there are important sensory symptoms and patients have paresthesia. Though we know that Guillain-Barré is a motor disease, there are sensory symptoms like tingling in the hands and feet when they come. And therefore, you must not say that nahi ho sakte GBS. Ascending means first lower limbs, then upper limbs, trunk, respiratory muscles, lower motor neuron facial palsy. This is how it can progress. The reason why a family physician should pick up Guillain-Barré syndrome is because you can treat it, and we'll come to that. Second question. Although it can affect axons of nerves, axons, you know what are axons, right? The middle blue portion is the axon, and the outer pinkish portion is the myelin sheath. Although it can affect the axons, typically, Guillain-Barré syndrome affects the myelin sheaths. It is often referred to as AIDP. What does AIDP stand for?
Autoimmune degenerative paralysis.
Incorrect. Audience? 10 points to audience. Acute inflammatory demyelinating polyradiculopathy. पॉलीरेडिकुलोपैथी मीन्स रेडिकल्स मतलब डॉर्सल रूट गैंग्लियन से जो निकलता है उसको रेडिकल्स कहते हैं, प्रॉक्सिमल पोर्शन ऑफ द पेरिफेरल नर्व्स. इट्स अ रेडिकुलोपैथी. इट्स polyradiculopathy, meaning multiple nerves are involved. It is demyelinating because myelin sheath, because of the inflammation, are destroyed. It is inflammatory and it is acute. So AIDP is the most common form of Guillain-Barré syndrome. Okay, I'll now call it GBS, okay? GBS usually presents 2 to 4 weeks after a GI or respiratory infection. While both viruses and bacteria have been implicated, which bacterium is most commonly associated with severe cases?
Campylobacter jejuni bacteria.
Campylobacter, 10 points to you, well done. Campylobacter jejuni is the bacterium. There are many bacteria associated with Guillain-Barré syndrome. One is Shigellosis. Shigella and Campylobacter are the prominent bacteria. And then there are viruses. Any viruses, do you know?
CMV.
Cytomegalovirus,
Then even
herpes simplex virus. Sorry? Epstein-Barr virus, excellent. HIV,
post-COVID.
COVID, SARS-CoV-2 that is, and Zika.
Zika.
These are the viruses which we know at least, there must be more, but this we know to be associated. So remember, it is a post-infective disease, a post-infective inflammatory disease, and the duration is 2 to 4 weeks. So every patient who comes with a paraparesis, initial weakness, ask them about diarrhea or respiratory tract infection in the preceding weeks. If there is history, you know that probably this might turn out to be GBS. Last question to the team. IVIG and PLEX are two specific treatment modalities of GBS.
Intravenous immunoglobulins and plasmapheresis.
Wonderful. Plasma exchange or plasmapheresis. PLEX is plasma exchange, but it is also called plasmapheresis. 10 points. This is another important thing for us to know. We have treatment. We have treatment which can be curative. And the treatment must be initiated within 2 weeks. If you delay the treatment, the patient can stay paralyzed for life or can die due to respiratory failure. So Guillain-Barré syndrome, again, GBS will need to be admitted in a major hospital where you have facilities for giving plasma exchange. IVIG you can give in a nursing home also, but you should have both available so that the neurologist can choose which is the correct therapy for this. Both are therapies which remove the antibodies that are causing demyelination. Okay. There is chance of 85% chance of full recovery in the paralysis within 1 year. It's a slow process, but within 1 year, the patient recovers fully 85% of the times. Sir, Mukesh, your question. Albuminocytologic dissociation on CSF is a feature of Guillain-Barré syndrome. What is albuminocytologic dissociation on CSF examination? We'll first ask him and then the team will help. Albumino, yeah, you can take the answer.
So you'll find albumin proteins are there in the CSF, but no cell counts or nothing. All is normal. So this is because of the antibodies which are formed.
Wonderful. So in viral transverse myelitis, which also presents with, say, for example, paraparesis, you get high cell count with the high protein count on CSF. But in Guillain-Barré, you get only increased protein count without an increase in cell count. Talia. Thank you so much. Full marks this time to them, 40. And let's have the final score. This score so far. Tie?
Team A 105, Team B 105.
इसमें 40 नहीं मिला, 30 मिला.
30, but the last question?
मिला नहीं 13, हाँ 30 plus 10. Yeah, right. So scores please.
Team A 105, Team B 105.
Okay, that's तालियां फिर से. Not bad. I think this is excellent performance by both the teams. I'm so glad. And now we go to the next round. This is the 7th round. I have kept a time limit of 12:35 for this, so we may not finish all the 10 rounds because we have the bingo to play. 7th round. Your topic is Parkinson's disease. Team A. In patients of Parkinson's disease, several non-motor symptoms commonly precede the onset of motor symptoms by several years. Two such non-motor symptoms are constipation and dream enactment. Name one symptom related to the special senses.
Anosmia.
Anosmia is the correct answer. Hyposmia or anosmia, a very curious feature of Parkinson's disease. The motor symptoms you all know, akinesia, rigidity, tremors, postural instability are the motor symptoms of Parkinson's disease. These patients sometimes for 7, 8, 10 years before Parkinson's motor symptoms develop have symptoms which are non-motor, non-specific also. Sabka constipation hai, sabko Parkinson's nahi hone wala hai. But constipation with anosmia or dream enactment means agar sapne mein cricket khel rahe hain, so they will start doing this in their dreams. Yeah? So dream enactment are features of a prodromal feature of Parkinson's, not specific and yet important. What can you do about it if they have? Don't tell the patient, okay? Someday we will have therapy to prevent Parkinson's and then maybe these prodromal symptoms will become important. Second, you have to do some acting here. Please enact the resting tremor for 5 points and the re-emergent tremor for 5 points, both of the hand. Can you stand up and show? Resting tremor first. Resting tremor first. Accepted, completely accepted. Unka pill thoda bada hai. Joking. So pill rolling is something like this, yeah? Very significant tremor, coarse tremor, and not just at the fingers, but also at the wrist joints, etc. Pill rolling or resting tremor. Now, re-emergent tremor. Concentrate on the word, re-emergent tremor. I'll tell you when to play the video. Just a minute now. No, you cannot help, but you can show it after they fail. So, a re-emergent answer.
Re-emergent is once this pill rolling stops for some time by voluntary action, then after some time again it restarts.
Yeah, but re-emergent more importantly than action tremor. Pill rolling or resting tremor is at rest. Their hand is by the side, it will rest. There is a component in tremors called postural tremor or action tremor, meaning you make them do this and they will have tremor. So first they are resting their hand like this, which is trembling like this. Then you tell them, okay, raise your hand, and then they raise their hand, and there for a few seconds the hand is steady, and then they start trembling again. Okay, re-emerging when action is done or posture is maintained. Do we have a video of this? Okay, yeah. Resting tremor. Raise your hand. Slight steadiness of the hand. And now, so the hand starts trembling again. That is a re-emergent tremor, very classic of Parkinson's disease. So if you can't differentiate between tremors, this re-emergent tremor is a very specific test that you can do. Okay. Next question. We give them 5 points for this. Next question. Hypomimia and sialuria are features of Parkinson's disease. What do these terms mean? Hypomimia for 5 points, sialuria for 5 points. Mic, into the mic so that I can give you points. Okay, time up.
Siluria is excessive salivation and drooling of salivation. Hypomimia is speech disturbance.
No. Anybody? Mask-like facies or less mimicking of the facial expression. That's why hypomimia is 5 points to team. Last question. In the treatment of Parkinson's disease, what is common to the utility of trihexyphenidyl and deep brain stimulation? What is common to the trihexyphenidyl is pacitane. What is the utility, not the side effect? Utility.
Control tremors.
So both treatments are predominantly relieving tremor. Okay, as you know, there are several motor components. There is postural instability, there is tremor, there is rigidity, and there is hypokinesia. Deep brain stimulation is a treatment used where the tremor is so bad that it is not controllable by medicines. Deep brain stimulation does not improve the other components as much as it reduces tremors. So tremors are, and similarly pacitane, that is trihexyphenidyl, is a drug for tremor of Parkinson's. Okay, we have an expert question here. Slightly difficult. I'll just put the answer, yeah. Kumar, levodopa is often combined with carbidopa, which is a decarboxylase inhibitor, so that the peripheral conversion of metabolism of levodopa is decreased. There is another enzyme inhibitor called COMT inhibitor, which may be added to the combination of levodopa and carbidopa. And you have to give me the full form of COMT and one example of the drug group. What is COMT?
Example is entacapone.
Entacapone is an example.
COMT is methyl transferase is MT. O is
No, so we'll give it to you. No points for that. Catechol, O, methyl transferase enzyme. So, of course, we don't need to know biochemistry so much, but suffices to know is that the decarboxylase inhibitor, that is carbidopa, its main function is to increase the blood levels of levodopa in the periphery. The main function of entacapone and tolcapone is to reduce the on-off phenomenon that a patient gets sometimes on levodopa. They will sometimes with levodopa have an effect of 4 hours, and then sometimes at 2 hours it will be off. So the on-off phenomena can be reduced by COMT inhibitors given with levodopa and carbidopa. The enzyme is both, like, unlike the carbidopa, which is only a peripheral, this is both peripheral and central. So we'll give 5 points for the last question. फुल फॉर्म नहीं दिया है एंड आप इनका पॉइंट आधा दिया नहीं, आधा फुल फॉर्म नहीं, एम्प्टी आंसर नहीं चलेगा, फुल आंसर चलेगा. कितने पॉइंट्स मिले? 8 एंड टोटल इनका बोल दो तो वी नो हाउ मच टू कैच अप. 140 एंड इनका कितना है?
105.
So you need at least 35 points to match. This is the last round, and 40 to win. Okay. The topic is Alzheimer's disease. Your first question. A person is said to have anterograde amnesia when they cannot remember new information, but they can remember events before the onset of amnesia. गजनी फिल्म देखिए. गजनी में क्या होता है, उसको किसने मारा, किसको मारा, वो सब याद है. यानी एमनीजिया के ऑनसेट के पहले सब याद, किससे बदला लेना है उसको याद है, मगर उसको नई इंफॉर्मेशन लिखनी पड़ती है या बदन पे या स्टिकर पे वगैरह वगैरह. सो दे कांट रिटेन न्यू इंफॉर्मेशन while remembering old information is called anterograde amnesia. A person is supposed to have retrograde amnesia when they can remember new information but cannot remember events before the onset. For example, car accident हो गया, वो पिक्चर में देखते हैं, फिल्मों में देखते हैं ना, कार एक्सीडेंट हो गया, मैं कहाँ हूँ वगैरह होता है, और पीछे का सब भूल जाते हैं, हस्बैंड कौन था, वाइफ कौन थी, कन्वीनियंटली सब हो जाता है. तो दैट इज कॉल्ड retrograde amnesia. Which type of amnesia is seen in Alzheimer's disease? Anterograde, retrograde, or both?
Both.
Incorrect answer. Anybody? Anterograde is the only amnesia seen in Alzheimer's disease. Okay. Next question. Oops. Amnestic MCI frequently represents early stage of Alzheimer's disease with a progression rate of dementia at 10 to 15% per year. Many of us can't remember ना drug names, वो brand name याद नहीं रहते हैं, बीवी का नाम याद रहता है, लेकिन काफ़ी चीज़ें बीवी को पसंद हैं वो याद नहीं रहती हैं, या husband का क्या खाना खाना है, ये MCI बोलते हैं, and we are always scared ये MCI will become Alzheimer's disease or not. 10 to 15% will progress. I don't know how many of you will come next year. So 10 to 15% will progress to dementia. What is the full form of MCI?
That is MMSE. That is not the mental confusion index. Wait, sir, let me. Mental challenge index है क्या?
Okay. Mild cognitive impairment. This was simple. Mild cognitive impairment is a very important condition that many of us have. I have it, for example. We must know how to identify and how to know whether it is progressing to. There is a test called mini-cog. Mini-cog is a simple test that you can do in your OPD where you have to show the patient 3 objects and ask them what, after 5 minutes, ask them what was shown to you. And you can ask them to draw a time on a clock, say 10 past 15, 10 past 3, and they have to draw the small hand and the large hand. And this mini-cog has a score, easily, I will post it to you. If the mini-cog is abnormal, then you may have to progress to further testing. Okay, so mild cognitive impairment. Next question. Cholinesterase inhibitors are typically useful in mild to moderate Alzheimer's disease. Cholinesterase inhibitors. Name any 2 of the 3 cholinesterase inhibitors.
Donepezil, rivastigmine, and amantadine, galantamine.
You are right. 2 out of 3 given, 10 points to you. Donepezil, galantamine, and rivastigmine. One important thing for the GP here, this will be prescribed by the neurologist. We will not be prescribing him. But if the GP prescribes for mild to moderate disease, Alzheimer's, these drugs, you must know that they will not be useful probably after 1 year of Alzheimer's disease. So neurologists will continue the medicine, CTOL. You know how everybody does that. Dual antiplatelet drugs by cardiologists, NSAIDs by orthopedic surgeons. Our job is deprescribing. So deprescribing these cholinesterase inhibitors will be very important because they cause anorexia, nausea, vomiting. The problem is that this is the commonest side effect of these drugs. And I have also therefore given you away the last question. But I will change the question. The reason why the GP should know is most of these patients of dementia are anyway malnourished, eating poorly, bad dentition, can't eat on their own, sometimes on feeds. If they get vomiting, it is disaster. Okay, so next question. What are the common side effects? I think you know the answer. Anorexia, diarrhea. Your question therefore will be, if cholinesterase inhibitors are drugs given for mild to moderate, which drug is given for severe Alzheimer's disease? Which one? There is only one drug used. There is a couple of more. Yeah?
Memantadine.
Memantadine is the correct answer. 10 points there. Again, you have to realize this. Memantine, I'm so sorry. Memantine is a drug used for severe Alzheimer's disease. And it is also of limited use. There is no cure for Alzheimer's disease so far. The monoclonal antibodies are being developed and probably will come into play. But memantine is a drug reserved for severe disease, should not be given in mild to moderate disease. All these drugs do what? They delay the further progression by a few months. Okay, sir, aapka question, Dr. Mukesh. Name one anterograde amnesia, a condition which lasts for only 24 hours usually occurs in 50 plus age group and involves what is called the broken record phenomenon, where the patient keeps repeating things. मैंने गाड़ी का चाबी किधर रखा, मैंने गाड़ी का चाबी किधर रखा, मैंने खाना खाया कि नहीं खाया. They remember everything 24 hours prior, but for 24 hours they keep on repeating things.
Stroke,
Stroke incorrect.
TI.
Any particular form?
TIA.
Transient global amnesia, TGA. Now, why do I talk about these conditions? They seem to be rare. This is not rare. You must diagnose. In your lifetime, you will see at least, if 40 years of practice, 5 TGAs, you will see at least. Transient global amnesia. What does the patient come in? Usually male, usually 50 plus. The patient will say, okay, the relative will say, ये बार बार रिपीट ही कर रहे हैं, उसको याद नहीं, वो मैंने उसको बोला तुमने गीज़र का स्विच बंद किया है, फिर वो बाहर आके बोलता है मैंने गीज़र का स्विच बंद किया है, बार बार एक ही क्वेश्चन, मेरी गाड़ी की चाबी मैंने ली है, मेरे ड्राइवर को मैंने भेजा है. रिपीटेड ब्रोकन रिकॉर्ड फिनोमिनन. एक ब्रोकन रिकॉर्ड कैसे बचती रहती है एक ही जगह पे, वैसे ब्रोकन रिकॉर्ड फिनोमिनन. एंड आफ्टर 24 आवर्स, मिरेकल, they are completely normal. So a good thing about the GP is that they can take credit. So you can give a placebo and you tell them that within 24 hours, full memory, no loss. Do that. And okay, that ends. We have 2 more rounds, but we'll skip that. And can we have the scores, final scores, please?
Team B 125, Team A 140.
Team A, Team B, both are winners. We'll give them prizes. Please stay on stage.
Thank you, sir.
Good. But you look good even in spec.
My husband tells me, don't face lenses.
Thank you. चलो, this time तो अच्छा किया. वो 4.5 भी मेरे को मालूम था, but you said 3.5, so I.
Again, thank you, Kumar. And we have something for Kumar and Mukesh. Thank you. Kumar, between the 3 of us, I would say about 500 working hours have gone into this conference, between the 3 of us. And this is Mukesh. Thank you, sir. Sorry? Names of the party, I am so sorry, I have not announced names. Because I have MCI, I will look up and check the papers. Team A, Sunita Manglik, Bhavini Furia, and Ramila Mehta. Ramila Mehta ji, the senior, raised hands, and we have Sunita Manglik, Bhavini Furia here, and Sunita Manglik there. And team B, we had Sheila Rathod, Rajni Golani, the senior person here, and Leena Bagadia. आपके साथ फोटो ले लेंगे फटाफट, दोनों टीम एक साथ. कुमार एक बार आ जाओ ना. मुकेश,
सर ने मेरे साथ वहाँ वो फोटो नहीं लिया इसलिए.
yes. Okay, after this we'll be playing the bingo, which will be a rapid fire bingo. We hope we'll be recording it on video and we'll be sending. So if you don't want to take notes during the bingo, you're fine. Yeah, thank you. Now close together. Look there. Look left. And left.
And right.
Okay. Thank you so much. Yeah.
Last statement you have to stop.
No, nobody gives. No, physio. It has to be EMG. No, treatment is there with pyridostigmine. That is a treatment. But diagnostic test they don't use now.
No, not that. For Alzheimer,
Alzheimer's, acha.
diagnostic,
Huh.
Alzheimer and all that.
So they said, no.
So no, do we continue or we don't continue?
After 1 year, useless. That's why Okay, the next game. Where is my game? Also, I would request Dr. Bhairavi Shukla, please come on stage. Where is she? मेरा हाउसी टिकट्स किधर है? You saw the canvas outside, the SOS canvas outside, which we would like you to take photos of so that you can Instagram them. We want slightly larger. This is the best audience we've had ever in SOS. So thank you so much. And so there are two types of ambassadors for any project. One is a brand ambassador and one is a branding ambassador. So all our branding in the form of canvases are made by Dr. Bhairavi Shukla, and both Nimish Shukla and Bhairavi Shukla, and they are also our brand ambassador. They keep on telling people, okay, this is marvelous, this is fantastic. वो publicity करते ही रहते हैं, and therefore great gratitude, and thank you so much.
Just a little bit, I want to say that I don't know if you all have noticed, but in the SOS logo, which is beautifully designed by Sir's team, in the first S, I put down the topics which Sir has covered so far, but that S wasn't enough to cover the topics. And in the second S, I've tried to put some take-home points which Sir has always, given us. That I was telling Sir that I don't know how many alphabets will be necessary to put down all the points. And in 2023, I've tried to put down the topics which Sir is going to cover now in SOS 2023. Wow. Thank you so much, Sir, for the opportunity. Thank you so much.
Her painting called Starry Nights by Vincent van Gogh. There's a painting by Vincent van Gogh called Starry Nights. Her hand-painted Starry Nights is permanently on my desk at the clinic. Yeah, thank you so much. Okay, now we go to bingo. You will help me because you will sit here. Before we dispersed, I also have to thank all the assistants who have absolutely been amazing in helping me. And this Dr. Rachita Narsaria here is one of the most hardworking person, done all the PPTs and all the audiovisuals. I have to thank Puneet and his team. Puneet, raise your hand. What is happening today is we are recording all the videos and we are putting them up on YouTube later after the editing is over. We are, of course, doing Facebook Live right now. Is it Facebook Live and YouTube Live? Both. YouTube Live is on, Facebook Live is on. They'll be on next week and next week, which we don't like to tell you. You see? So do come here because live is another experience. वो Facebook पे जाके आधा घंटा तुम खाना खाने जाओगे, Facebook, WhatsApp पे जाओगे, यहाँ पे एक attention span रहता है. And the third thing that will happen is there are two photographers, Ravi and his team. They did still photography, and my daughter Tanvi has been doing both still and small video clips, and we will be posting those video clips sooner than the YouTube clips. So maybe, and everything will be posted only on one place, that is our SOS registration group first, and of course there will be YouTube links. So thank you again, and we start with bingo. Bingo means आपके पास टिकट है. टिकट है, ये टिकट है. जिनके पास टिकट नहीं है प्लीज पूछ लें. सबके पास बॉल पेन है और टिकट है. Once you have a ticket, you will just have to scratch very simply so that it still remains readable the word or the answer that is given. All have codes. They're not full forms. For example, SAH stands for subarachnoid hemorrhage. All tickets are, we have tried to randomize the tickets. Sometimes tickets will overlap, but we've tried to randomize the tickets so that there are different tickets for everybody. Prizes are for first line, second line, and the first zigzag line. By zigzag line, we mean either this way 5 letters or this way 5 letters. Okay? And then there are 2 full houses. Right? We have 40 clues. मैच कितने बजे? 1:30. 2 बजे ना. हाँ. YouTube live के बदले match live. So basically, India-New Zealand match, the result is not material because India will qualify anyway. So we have till 1:30 max to play. Whatever clues we can finish, we will try to finish. If anybody needs to leave from here, they can of course leave. There is no reason not to leave. You might be in a hurry, but just tell us your name before you leave. Okay? ED आएगा ना? Okay. Your first question. All this will be question answer. You can shout out the answer and then we tell you what to scratch from your ticket. All are learning points for the family physician. All are important points for the family physician. Flunarizine, that is Sibelium, is often prescribed as a migraine prophylactic drug. One of the psychiatric side effects of flunarizine, if given for long term, is depression. What is the other side effect? No? Drug-induced Parkinsonism, DIP. The answer is DIP on your tickets. Very important. We give Sibelium left, right, and center for headache, which can be left, right, and center. We must restrain ourselves from prolonged use of 2 or 3 very important areas of flunarizine. Flunarizine is a drug which can be given for 3 months and stopped. And the effect of prophylactic effect of flunarizine will last for a few more months. And then we can restart and stop. That is a good way to give flunarizine because it has a prolonged action even after stoppage in preventing attacks of migraine. So that is one important thing. And depression, if given for more than 1 year, drug-induced Parkinsonism, if given for long term, are 2 major side effects. Any drug that rhymes with flunarizine, which causes cinnarizine. Another drug called Stugeron or cinnarizine. Again, same problem. Many patients with vertigo keep on taking Stugeron, and drug-induced Parkinsonism is a problem. So that is your DIP. Plummer-Vinson syndrome and Willis-Ekbom disease share a common etiology. What is Willis-Ekbom disease, better known as? The hint is in the Plummer-Vinson syndrome. Plummer-Vinson syndrome and Willis-Ekbom disease share a common etiology. What is iron? And what is the Willis-Ekbom disease called? Iron deficiency is the correct answer of the common etiology. What is Willis-Ekbom disease? RLS, restless leg syndrome. Very important message here is restless leg syndrome can be either idiopathic or due to iron deficiency. It can also be due to CKD, etc. But iron deficiency is an important correctable cause of restless leg syndrome. And you can give iron if serum ferritin or serum iron studies are low and cure the restless leg. So you don't need to give dopaminergic drugs like pramipexole or drugs like pregabalin for prevention of restless leg syndrome. Right? Another important thing is pregnancy. 25% of patients develop restless leg syndrome. And this restless leg syndrome is treated with iron irrespective of iron levels. So you can give iron to patients of pregnancy who have restless leg and still they will feel better. Okay, so that is RLS on your tickets. Which painful neurological disorder may be precipitated by a smile? Trigeminal neuralgia. Trigeminal हंसने की भी कीमत चुकानी पड़ती है, right? Trigeminal neuralgia is a condition which can be precipitated by smacking your lips, by touching your face, by smiling, by brushing your teeth, by shaving, that is trigeminal neuralgia, and we will go to the next clue. Sorry, the TN is the code. There are 2 causes of dementia that can be reversed with surgery. 2 causes of dementia that can be reversed with surgery. One of them is chronic bilateral subdural hematoma. Which is the second? NPH, normal pressure hydrocephalus. What is important for the GP is that any patient who seems to be having cognitive dysfunction, dementia, before labeling the patient as Alzheimer's or any other vascular dementia, etc., you must do a CT scan or sometimes an MRI for NPH and determine that there is no such thing. If there are bilateral subdural hematomas, they can cause cognitive dysfunction, gait disturbance, slurring of speech, all these which resemble dementia. And just burr-holing and removing the subdural hematomas may be curative. Similarly, in NPH, shunt surgery, ventriculoatrial shunt or ventriculoperitoneal shunt may relieve the NPH, giving significant relief in dementia. That is NPH. NPH, normal pressure hydrocephalus, diagnosed on CT scan and quantified on MRI sometimes. If a young woman on OC pills or a young woman who is pregnant presents with headache that progresses over days and weeks, headache that is gradually progressive in severity over days and weeks, what cause of the headache must one rule out curable cause? Sorry? It's not called DVT, it is called cerebral venous sinus thrombosis, CVT on your tickets. Cerebral venous thrombosis. This is an important cause of headache, especially if the patient is on OC pills or is pregnant, or in alcoholics. Young alcoholics can get CVT. If they come with headache, never ignore the headache if it is gradually progressive over days and weeks. If it is progressive, you must do, what is the investigation? MRV, MR, magnetic resonance venography, is the diagnostic test for cerebral sinus thrombosis, and this is treated with anticoagulants. Otherwise, it can cause an infarction, a parenchymal infarction in the cerebrum. CVT. Midodrine and fludrocortisone are drugs used in recurrent syncopal episodes due to orthostatic hypotension. In which form of orthostatic hypotension does the BP drop a few minutes after assuming the upright posture? I will repeat the question. Orthostatic hypotension means postural hypotension. Patient is supine, BP 120/70. You make the patient stand, BP immediately checked 90/60. More than 20 millimeters of drop is postural hypotension. 20 millimeters of systolic drop, 10 millimeters of diastolic drop. If the patient is standing immediately and gets hypotension, we call it immediate orthostatic hypotension. Now there is something called delayed orthostatic hypotension, meaning the patient is supine, patient stands in the night, goes to the bathroom, in the bathroom after entering, falls. Not immediate, maybe a couple of minutes after. This is called delayed orthostatic hypotension. What is the typical cause of delayed orthostatic hypotension? Drugs will cause almost immediate hypotension. Autonomic neuropathy. Autonomic neuropathy is the commonest cause of delayed orthostatic hypotension. And the cause of autonomic neuropathy can be age, diabetes, for example. Yeah. Then your key is OHAF, orthostatic hypotension due to autonomic failure. OHAF. Okay? That is done. These were both the same. Luckily. Atrophy of this portion of the limbic system is the most consistent feature of Alzheimer's disease. We said frontal lobe में इतना problem नहीं होता है जितना इस area में होता है. Limbic system का कौन से area में? Hippocampus, and your code is hippo. Hippocampus is a very important area in the brain. Multiple problems related to hippocampus. There's something called mesial temporal sclerosis, which is a form of epilepsy. We used to call it temporal lobe epilepsy. That is atypical epilepsy. That occurs due to hippocampal degeneration. So hippocampus is an important area even for Alzheimer's disease. Hippo. Your next question. Which brain tumor does not metastasize and has a mean survival of 14 months. Multiforme. Glioblastoma, multiple grades are there. The worst grade is called glioblastoma multiforme, which has a lifespan of around 14 months, whatever you do. No cure. Important thing about, I mean, I've seen so many glioblastoma. How many of you have seen bad brain tumors that have killed in your patients? Multiple people. Now, sir, Suresh bhai, अरे देसाई साहब ने तुम्हारा नाम से भूल गयो Surendra. If a patient of glioblastoma multiforme comes with an MRI or a CT scan and he has a large tumor and the prognosis seems bad, it's a grade 4 glioblastoma, and the patient has been advised surgical removal followed by certain oral chemotherapy. What is your advice to the patient? Given the fact that the therapy will prolong his life by an average of 3 months, what is your advice to patient? Palliative care, no going for surgery, or this is very important. The neurologist will invade because they are invasive therapeuticians. The neurologist will invade, the neurosurgeon will invade. We must try to be conservative. What are we giving 3 extra months for? We are giving 3 extra months for going to the hospital, coming back, going to the hospital again, coming back. That is what we are giving the 3 months for. We cannot do that. We have to keep the patient with the relatives once we know the prognosis. We have to say, okay, it is incurable. You try your alternative therapies, but please don't do surgery and chemotherapy. That is very important. Okay. Answer क्या था? GBM. Sorry, एक ही था उसमें. Okay. Lewy body dementia, progressive supranuclear palsy, corticobasilar degeneration, and multiple system atrophy. All very esoteric terms for GPs, all very difficult terms for GPs, and we don't know most of these conditions, right? These conditions have features of Parkinson's disease, which is why it is important for us. And they have additional abnormalities besides Parkinson's disease. Some patients have postural hypotension such that they will fall backwards. Some people have psychosis. Some people have dementia. What are these called as a group? Parkinson plus, Parkinsonism plus, or PSP on your card. It is very important. What is the basic testing that we can do in a Parkinson's disease patient? Patient comes to you with tremor, with cogwheel rigidity. A patient comes to you with those typical short shuffling gait, stoop posture, and postural instability tendency to. What is the basic thing that you can do to know whether the patient is Parkinsonism plus? Look for dementia, because Parkinson's typical disease does not have dementia. Cognitive disturbance, speech disturbance, look for that. Look for psychosis, abnormal behavior, hallucinations. Levodopa syndopa can cause hallucination, but before levodopa has been started, hallucinations occurring in a patient. Patient with significant postural hypotension. Patient with ask the patient simple, look up. Supranuclear gaze palsy, they can't look up. They can't look down easily. Whenever this happens, why is it important for you to recognize? Because these patients will not respond very well to your syndopa, etc. You must refer such patients, and unfortunately, nothing much can be done for them. It's a progressive, very, very morbid disease. Okay. This was as PSP. And now, in which disease will you get fascinating, accelerating gait and freezing both in the same walk? Parkinson's disease, or GIP. Gait in Parkinsonism is what I am trying to tell you. Now, very typical gait. I am not a good actor, but very typical gait. You know that the stoop posture, bent hands, bent legs, and patient has initiation problem, meaning they will not start when instructed, but when they start, they will accelerate. It's called fascinating gait. I won't accelerate. And they have freezing. Somebody comes from samne se, they will just freeze. And then when the danger passes, they may start walking again. Hand movements are minimal. They don't move their hands. So that is your classic Parkinson gait. The answer was GIP. कितना हो गया मेरे को 2 मिनट के बाद बोलना. Next, another important area for you to know. Café-au-lait vacuoles are seen in which form of peripheral neurological disorder? Neurofibromatosis or peripheral neurofibromatosis, PN on your ticket. There are 3 forms of von Recklinghausen disease. Von, VON, I think, von, keep von, Recklinghausen's disease. The one important form, of course, is the most common. So you have patients who come with multiple nodules on their body, trunk, limbs. So whenever, another thing that I like to do, we always should appear like magicians, right? And the patient should be surprised. Okay, आपको ये कैसे मालूम पड़ा? So whenever you find a nodule here, somewhere, and you feel it's a firm nodule, not like a lipoma, very soft, it's a firm nodule, like a neurofibroma, your hand should immediately go to the upper abdomen, here, and you start palpating here, and you'll say, idhar bhi hai tumko. Aapko kaise malum? The immediate reaffirmation for the patient that this doctor knows his work. So very common on the abdomen, especially the front, and very common on the dorsum of forearms. These are peripheral neurofibromas, often called lipomas because they feel like lipoma, but they're not soft, they're firm. And often they have a little dimpling on their surface. And you can move them a bit, but you can't squeeze them, flatten them like you could maybe flatten a lipoma. And lipoma, of course, is translucent. They will ask you, what does the patient ask you? Ye khatarnak hai kya? Will this become a cancer? What is your answer? The answer correct is yes. The correct answer is a few of them do become malignant, but you will always say no. PN was the answer, peripheral neurofibromatosis. Okay, kitna? 12. We have done 12 out of the 40 and we have 20 minutes more. We'll try to do more. कुछ तो प्राइज लेना है, थोड़ा सा लाइन होना चाहिए. Okay. PN. You want all answers to be repeated? Give me 2-3 minutes. Huh? Yeah, alphabets I'll answer. देता हूँ. But optimism नहीं होना चाहिए. मतलब optimism की वजह से आप पूछ रहे हैं. वैसे आपका attention था. Okay, shaving the chin can precipitate trigeminal neuralgia. Which cause of unconsciousness might be precipitated by shaving the anterior neck at the platysma? Wonderful. Carotid sinus hypersensitivity. Shaving bhi khatarnak hai. CSH is the carotid sinus hyperactivity. Hypersensitivity. Carotid sinus either hote hain at the junction of the bifurcation of the carotid artery, and carotid sinus has autonomic receptors, and if there is atherosclerosis there, an atheroma there, then if you do carotid sinus massage or somebody wears a very tight collar, then they can get a syncopal episode, and that is called, some patients get such syncopal episode that they have to be put on a pacemaker device because the bradycardia can be devastating and repeated. Or they may have to undergo an endarterectomy in the carotid region. What we have done so far is RLS, TN, NPH, CVT, PN, CSH, DIP, OHAF, HIPPO, GBM, PSP, and GIP. Okay, we go to the next. If a chronic alcohol user presents with generalized tonic-clonic seizures 24 hours after the most recent alcohol ingestion, what disorder should you suspect? 24 hours after. No, one case doesn't cause convulsions. It is rum fits. So alcohol seizures occurring 24 hours after the last drink. So rum fits are a form of withdrawal fits. Alcohol withdrawal 24 hours, they get convulsions. These are generalized tonic-clonic convulsions. Alcoholics can get convulsions due to many reasons, right? One is alcohol intoxication itself. One is fall, causing head injury, causing a seizure. And this is rum fits, which can cause a seizure. RF on your ticket. Which disorder characterized by confusion, agitation, and the need for IV diazepam and IV thiamine may occur in alcoholics? Again, you are stuck on Wernicke's. No. Delirium tremens. Very important. Another alcohol withdrawal syndrome is DT, delirium tremens. It has been colloquially called the pink elephant, seeing pink elephants, gulabi hathi dikhte hain. Basically hallucinations occurring after stopping alcohol, characterized by confusion, which happens in Wernicke's, agitation, which does not happen in Wernicke's, and therefore they have tremulousness and autonomic dysfunction, severe hypertension or hypotension, tachycardia. These patients have delirium tremens. You have to sometimes give 100, 200 milligrams of IV diazepam and 500 milligrams per day of thiamine to such patients. DT and RF were the letters, last two. DT and RF. Jaldi 5, yes. क्या मिला? दो एक टिकट दिखा दीजिए सिर्फ. इनको दिखा दीजिए. हाँ. क्या? ओके, आप वहीं रहिए, जो ना नीचे मत आइए, मैं घबरा जाऊंगा. ओके, PSP, RF, DT, आपने क्या क्लेम किया है सर? हाँ, जिगजैग नहीं हुआ है, वो ET चाहिए. ओनली ना, जल्दी 5 नहीं था. सॉरी, जल्दी 5 तो था ही नहीं ना. हाँ, बैठ जाओ. सॉरी, मैंने मिस्टेक किया है. One zigzag, RLS, CVT, DT, DIP, PSP is a correct zigzag. Ma'am, your prize. कोई है और zigzag line? Okay, now I think we'll have quick. हाँ? क्या है? आप खाली बोल दो line. खाली बोल दो. RF बोला? हाँ. Okay. या नहीं. That is full house. ये नहीं, full house नहीं है वो. Next. अभी बाकी क्या हुआ? सेकेंड लाइन बाकी है. एक zigzag और देंगे जो उल्टा zigzag होगा. This zigzag was something that started from top left. Now you that kind of zigzag. And now वो वैली वाला था, ये पीक वाला आएगा. ठीक है. ओके. एंड 13%, another important area for us, very important outpatient fact. 13% of focal motor seizures. Focal meaning खाली ऐसा. You know what is Jacksonian march? We spoke about Jacksonian march. Is you start with the fingers, the seizure, then go to the wrist, then go to the elbow, and go to the shoulder. This is called a Jacksonian march. ये कब होएगा? जब the right frontal lobe का upper limb portion is having a seizure onset. 13% of focal motor seizures like Jacksonian march may be followed by limb weakness, paralysis, a condition named after physiologist Robert Todd. What is this condition called? Simple, na? Hint दे दिया. Robert Todd, Todd's paralysis, TP. Now, why did I give the name of Robert Todd? Just a second. Robert Todd का नाम क्यों बोला मैंने? Todd's paralysis is the name. Todd's paralysis मतलब उसको हुआ था? Robert Todd को हुआ था? नहीं ना, उसने किसी को दिया था? तो फिर Todd's paralysis क्यों बोल रहे हैं? So there is this नया nomenclature आता है ना, which is politically correct nomenclature. कि Todd's paralysis नहीं बोलने का, alcoholic नहीं बोलने का, user of alcohol बोलने का. HIV पॉजिटिव नहीं बोलने का, लिविंग विथ HIV बोलने का, मेरे जैसे को ओबीज नहीं बोलने का, मेरे जैसे को ABCD बोलने का. ABCD नहीं मालूम? ABCD क्या है? Adiposity based chronic disorder. Politically correct, right? So, टॉड्स पैरालिसिस में अपॉस्ट्रोफी एस निकालना चाहते हैं कुछ लोग, जैसे बेल्स पॉलिसी नहीं बोलते, बेल पॉलिसी बोलते हैं, और पीडियाट्रिक्स में तो एकदम कंफर्म हो गया है कि डाउन सिंड्रोम नहीं बोलते, डाउन सिंड्रोम बोलते हैं. दैट इज द पॉलिटिकली करेक्ट वे. ओके, सो दैट इज टीपी. सॉरी, आपका कुछ हुआ, क्या हुआ, कौन सा जिगजैग? तो आपका फर्स्ट लेटर कौन सा है? हाँ, वो नहीं देने का है. तुम्हारा फर्स्ट लेटर कौन सा है? फर्स्ट लेटर दिखाओ ना खाली. नीचे का है कि ऊपर का है? नीचे का मिल जाएगा. आप खाली 5 बोल दो. CHF हुआ, CSF, CSH हुआ, CHH नहीं हुआ. हाँ, CHS हो. सॉरी. आपका क्या था, वो था ना, लेफ्ट टॉप से शुरू हुआ ना आपका? हाँ, वो हो गया था. तो आपका ओके. नाउ वी हैव ओनली द बॉटम लाइन रिमेनिंग. सर इज गोइंग फॉर द मैच, सर, बट गो, नो प्रॉब्लम. नाम नहीं चाहिए, मेरे को 4 पंक्तियां सुनानी है. मैंने ये सुना, आपने सुनी है, लेकिन वापस सुने. रुखसत हुए तो आंख मिलाकर नहीं गए, वो क्यों गए ये भी बताकर नहीं गए, इशारा ही कर देते, बुरा भी न मानते, वो हाथ की उंगलियां भी दिखाकर नहीं गए. ओके. This question we already addressed before. In which cause of peripheral vertigo is oral steroids the treatment of choice? Vestibular neuronitis, VN, vestibular neuronitis. Just a little fact, vestibular neuronitis involves the vestibular system of the vestibulocochlear nerve. When both vestibular and cochlear components are involved, vestibular means deafness, tinnitus, vestibular means tinnitus and vertigo, cochlear means deafness. When both vestibular and the cochlear symptoms are involved due to a viral infection like herpes, what is it called? It's called labyrinthitis. Acute labyrinthitis is also an indication for steroids, like acute vestibular neuronitis is an indication for steroids. Okay, VN, that was the last 2, and now we have bottom line baki hai, full house baki hai. Urolithiasis क्या होता है? Stones in the ureter. Cholelithiasis क्या होता है? Stones in the choledocholithiasis क्या होता है? Stone in the bile duct. और otolithiasis क्या होता है? Semicircular canal. What disease is caused by otolithiasis? BPPV is your answer. BP. Last line. Please just tell me the words of the last line. Please give her a prize. You have last line. Okay, so 2 last lines claimed, and now we have the full houses pending. Okay, we have 2 full house prizes. So if 3 of you claim together, you can fight over it outside. Outside, but okay. Sorry, you said something. If a patient, again, this is a very important thing because so many of our patients are on SSRIs. You know SSRIs? Serotonin, selective serotonin reuptake inhibitors. I'll just name a few. We have fluoxetine, paroxetine, sertraline, citalopram, escitalopram, doxepin. Doxepin नहीं ना? Doxepin तो TCA है. एक और रह गया. Fluvoxamine. फ्लूऑक्सेटिन बोल दिया था, फ्लूवोक्सामिन, वो दोनों बोल दिया मैंने. तो ये सब जो ड्यूलॉक्सेटिन नहीं, ड्यूलॉक्सेटिन नॉट SSRI, SNRI. ओके, तो SSRI बहुत कॉमन है, आपको मालूम है. आप में से कितने लोग SSRI लेते हैं? मत बताइएगा. If a patient is on SSRI and this patient also has migraine, and if this patient is given sumatriptan or rizatriptan for migraine, they may develop some very severe altered mentation, agitation, and hyperreflexia with clonus. You know clonus? Aisa? What is this condition called? SS, serotonin syndrome. Serotonin syndrome. They will develop serotonin syndrome. Remember, serotonin syndrome is a very important problem because of us. We cause it. If a patient is on linezolid antibiotic, patient has cellulitis and significant pain, and this linezolid patient you give tramadol, Ultraset, or you know those drugs, tramadol with paracetamol, plain tramadol like Tramazac. If you give Tramazac to a patient on linezolid, they can develop the serotonin syndrome. Very important to know this because we cause it. We cannot cause serotonin syndrome. It can be potentially lethal. SS. Yes. 2 prizes for? No, 1 prize for first line था. अभी bottom line भी हो गया. अभी खाली full house. आप दोनों का ticket मिला के देख लो. Your question. Other than ISSHL, that is idiopathic, sudden, sensorineural hearing loss, you heard of that, right? Other than ISSHL, which ear disorder may be treated with intratympanic steroids? Meniere's disease is the correct answer. MD. Meniere's disease का 4 symptom होता है. क्या होता है? Tinnitus, hearing loss, vertigo, or ear fullness. 4th most important symptom. Tinnitus, vertigo, deafness, and feeling of fullness in the ear. Because that makes it more characteristic. बाकी सब तो तीनों बहुत चीज़ों में होता है. If you have Meniere's disease, the most bothersome, deafness हो तो चलता है. कभी कभी एक ही कान में होता है, hearing aid कहीं लगा सकते हैं. Tinnitus is so painful. And sometimes you have to give something more. Intratympanic steroids may be given. What it does better is treats vertigo better than tinnitus. But tinnitus may be marginally improved. MD. So that was, अभी बाकी है, many pending. 10 more minutes to go, after which I have to pay 2,000 extra for the hall. If an elderly person presents with dementia, headache, somnolence, or seizures, what post-traumatic condition should be suspected? Subdural hematoma. I have told you this, that subdural hematoma can mimic dementia. So a treatable cause of dementia that we have spoken of, SDH. Next, 7-11 breathing is the treatment of choice for hyperventilation syndrome. What is the neuromuscular manifestation of this syndrome? ये जरा वापस बोलता हूँ. 7-11 breathing. What is 7-11 breathing? यानी 7 काउंट को इंस्पिरेशन, 11 काउंट का एक्सपिरेशन. अनुलोम विलोम जैसा, ठीक है? You teach the patient this when it happens, when she can't get attention. Why she? Because it's more common in women. Hyperventilation syndrome. When this occurs, you give a 7-11 instruction, or you can ask them to breathe into a brown bag. What is the neuromuscular manifestation? Tetany, wonderful. Hypocalcemic tetany, the symbol of calcium with 2+ signs is on your housey sheet. Hypocalcemic tetany. Sorry? CU अलग है, CA अलग है. Yeah. Next. A patient of hyperemesis gravidarum. You know what happens in hyperemesis? They will keep on vomiting, usually first trimester. Presents with dehydration to you and is given IV DNS. Fluids are given. And she now develops confusion, ataxia, squint. What has happened to her? Now the answer is Wernicke's encephalopathy. We again, I am repeating this, we associated Wernicke's and giving of thiamine with alcohol. But we have to think of fasting as one possible problem, and hyperemesis gravidarum is an important cause of thiamine deficiency. And you know, in hyperemesis we give fluids, and this time we don't think of giving thiamine. We must give thiamine to such patients. Okay. B1 for thiamine is the key code, B1. Bell's palsy is a form of lower motor neuron facial palsy. It is better treated with steroids than with acyclovir. Which lower motor Bell's palsy is better treated with acyclovir than with steroids? Ramsay-Hunt syndrome, RHS. I hope everybody knows what is Ramsay-Hunt, but I'll explain. Lower motor neuron facial palsy, meaning forehead involved, eyelids involved, face involved, and even platysma involved, lower motor neuron. And commonest cause Bell's palsy, which is due to herpes simplex virus inside. Then there is herpes zoster virus, which can cause a lower motor neuron. But there you will have vesicles, and vesicles will be here in the pinna. And these vesicles you must look for in every patient of LMN facial palsy. You will treat it as Bell's treatment steroids. Steroids alone will aggravate the zoster. You have to give acyclovir or valacyclovir. In patients with Ramsay-Hunt, you may not give steroids and just give the antiviral drug. RHS. If an elderly person presents with features of dementia, हो गया, sorry, ये तीनों हो गया. कितने बाकी हैं लोगों के? एक किसका बाकी है? एक, दो, आपके 5 बाकी हैं. आप जा सकते हैं, मतलब जा सकते हैं. इस नाचीज के लिए उस मैच को मत छोड़िए. ओके. नहीं 10 नहीं बाकी हो सकता. हमने टिकटें ऐसी बनाई हैं कि इतनी शर्मिंदगी आपको नहीं सहनी पड़ेगी. ओके. फर्स्ट सिम्टम ऑफ दिस डिजीज इज डेफनेस और tinnitus. First sign of this disease is loss of corneal reflex. First symptom, deafness or tinnitus. First sign, loss of corneal reflex. यानी कॉर्निया को रुई से ऐसा किया, आंख ब्लिंक नहीं होती. Loss of corneal reflex. What brain tumor am I talking about? CP angle tumor, acoustic neuroma. AN on your tickets. Now this is one brain tumor that you can magically diagnose and impress the patient. Okay? Patient says deafness है, तुमने बोला ऐसा भिन भिनाती हुई आवाज़ सुनाई देती है, तो हाँ सुनाई देती है, तो आँख खोलो, रुई लगाओ, आँख ब्लिंक नहीं होती है, जाओ CP एंगल का खाली CT स्कैन करके आओ, and CP angle tumor. A beautiful diagnosis to make clinically, rare diagnosis, but beautiful diagnosis to make, and the patient will usually require surgery, usually if the deafness is significant. Sometimes they get even a facial palsy. But small acoustic neuromas are conserved, so you may not require surgery at all. Okay, next. Haji. AN, sorry, AN. 3 minutes baki. Which disease should one suspect when Parkinsonism is associated with dementia and psychosis? Parkinsonism plus, बोले ना, उसमें से एक variety है dementia and psychosis. Lewy body dementia, LBD. Another disastrous disease with no cure. Parkinsonism है, आपने देख लिया कि Parkinsonism है, tremor इतना नहीं होता है उसमें. More rigidity, more akinesia, but psychosis and dementia. So any Parkinson patient who does not have significant tremor, your red flags are up. You must think of Parkinsonism plus. Less tremor, but more rigidity, etc. Sorry, full house? Can you please just say the words? Wonderful. Please, yeah, Shweta, pulse oximeter to him. 6 मार दिया, लास्ट बॉल 6 नहीं, लास्ट बॉल नहीं था, फिर भी 6 मार दिया. या मेरे पास टाइम कम है और 2 मिनट और है. एक फुल हाउस ट्राई करता हूँ. किसका एक बाकी है? बहुत सारों का एक बाकी है. We have LBD. I'm not done one of that. What term is used to describe cryptogenic neurological disorder characterized, cryptogenic means unknown etiology, neurologic disorder characterized by sudden falls due to truncal or lower limb weakness without affecting consciousness and without postural hypotension. I'll repeat. Suddenly ऐसे गिर जाता है. Suddenly. Usually चोट नहीं आती. Patient कहेंगे मुँह पड़ी गई. शू थैलू, चप्पल स्लिप थैलो, कहीं ठेस वागेली, नहीं कुछ नहीं हुआ था, मुँह पड़ी गई. At home, outside home, more commonly outside home than inside home, they just fall. And they fall, sometimes have minor injuries on the knees, etc. Sometimes, usually fall forward, almost never fall backward. And you do everything. You look for postural hypotension, you look for skeletal disorders, etc. Nothing found. Cryptogenic. Unfortunate disorder. Not uncommon. And no treatment. What is it called? What is this called? Drop attacks. DA. Drop attacks. Yes, sir. आप दूसरी बार बोल रहे हैं? नहीं, वहीं से पढ़ लीजिए. बाकी है? कौन सा बाकी है? हाँ? CTS बाकी है? आता है. Last. So atonic seizures is a cause of drop attacks which the cause is known. Where it is cryptogenic, this is the problem. What is this dystonia called? I have a pen in my hand, there's a paper on this. I write and then I gradually go like this. Writer's cramp, WC, writer's cramp is a very unusual form of dystonia where only writing, once you start writing, does the dystonia appear like this. And it's difficult to treat, often drug induced, and you may have to give botulinum toxin in the hand. WC is the unfortunate abbreviation. So carpal tunnel syndrome is the answer, CTS is the answer. We know that we get paresthesias in the 3 or 3.5 fingers, including the thumb. And carpal tunnel syndrome, usually bilateral when it is idiopathic, usually bilateral when it's rheumatoid arthritis related, sometimes unilateral when there's a local compression. And we know what is the sign called? Fallon sign, P-H-A-L-E-N, Fallon sign. You do this, ask the patient to hold the hand, 30 seconds, they start getting paresthesias in the hand. You do this reverse Fallon sign, that can also precipitate. You put the hammer on the carpal tunnel, Tinel sign, and you can precipitate this. Some people give steroids, not to be given. Some people give pregabalin, gabapentin, because paresthesia, etc. No indication of pregabalin, gabapentin. No, none, nil. And splint or surgery. Decompressive surgery where you remove the pressure on the nerve. Yeah. Sir ka full house hai. Can you please give the pulse oximeter? Do we have a pulse oximeter here? Good hand, yeah, big hand of the second full house of the day. And all these clues, all the talks that we had, all the 1 pages that we have written will be combined at the end of the 3 sessions into a booklet as a PDF and will be given to you. So, no, thank you, not bolo, paro. आ जाते हैं PDF, कहाँ चला जाते कौन से. Hope to see all of you plus more next Sunday. Thank you for coming.